important too. In many instances, we assess them in our patient. Lawton scale is one of those instruments that you can use. Each of the instrumental activities or daily living items has 3 to 5 qualifier or choices that closely resembles the client's highest functional level, and that performer will be assigned 0 or 1. The summary score ranges from 0 to 8 for women and 0 through 5 for men, in order to avoid gender bias. For example, in our society, for the most part, men usually don't cook, so maybe food preparations, you will eliminate it for women, as an example. So maybe housekeeping, maybe a lot of men don't do housekeeping, maybe you eliminate that for men. So in one sense, assessing instrumental activities of daily living, Lawton is good to use because it also remove or avoid potential gender bias. Again, it's another instrument that is easy to use. You join assigned number based on the performance of the patient, 0 or 1, and then you add them up. Very simple. It is objective, represented by numbers, so it is good. So, basic activities of daily living function, functional independent measure, CATS ADL measure, Lawton IADL measures are important measures. They are simple to use. You can use them. There are specific scales for specific disease, such as myasthenia gravis scale, but I'm not going to go into details about that. To let you have an idea of the fact that those scales also exist. Those outcome measures for specific conditions also exist, and you can use them if you want. Health-related quality of life is one of those things that physiotherapists take care of in patients. There are measures that are used in assessing that too. SF36 is one of them. Sickness impact profile is another one. So again, overall health measure is what rehab professionals will also have to intervene in a patient for. We need outcome measures to be able to do that, to assess that. Health-related quality of life, SF36 is one of them. Sickness impact profile is another one. Again, these instruments are simple to use. They are not difficult to use. What is SF36? It's a short form health outcome survey form, 36 item, self-reported questionnaire by patient, covering 8 health domains, including limitation in physical, social, and usual roles in the society. Mental vitality, perception of health, and bodily pain. Short, 36 items. You score all the items on a scale of 1 to 100. 100 representing the higher level of functioning possible, and you sum up the score, and the aggregate score is computed as a percentage of points for that patient. Again, we use short form health outcome survey as a survey instrument to assess related quality of life of a patient. Simple to use. Physiotherapists, occupational therapists can use them. Very important. Sickness impact profile is another measure that is used frequently in rehab. Again, assessing the impact of an illness on a patient, very, very important. We assess them, and sickness impact profile is one of those measures that we can use, and it is important. How do we score them? It's a 136 items measure that is used to score patients in a broad measure of health status. So you can see it's very simple. And the response is yes or no. That's all you need. The patient will be answering the question, yes or no. That's all. Okay? It also assesses psychological domain, in 12 categories. And the good thing about this measure is it also assesses sleep and rest, eating, work, home management, recreation and pastimes, walking or ambulation, mobility, body care and movement, social interaction, alertness behavior, emotional behavior, and communication. Don't be intimidated by all these categories. They are things that are very, very simple. This sickness impact profile, very simple to use. You can use them on your patient. Maximum core is 100%. 0 represent good health status, 100 represent a very poor health status or a medium impact of illness or behavior on that patient. Again, very simple to use. You can use them. They are not difficult to use, and they represent number. They can be objectified, so you can use them. It's important. Yeah. So, in addition to short form SF36 to measure general health status, sickness impact profile is another measure that you can use. Again, all these are very simple tools. They can be used. You can pull them online. They are not difficult to get, and you can use them. Numbers that they give you represent something. Use it. Now, patient experience questionnaire is another important health outcome measure. Remember, in the beginning of my lecture, I was emphasizing that physiotherapists, occupational speech language therapists, audiologists, we are providing care for patients to remediate their impairment, to eliminate their functional limitation. And if there are participation restrictions, we eliminate them. But I also said, talk about the fact that satisfaction with care is also very, very important. Imagine two patients. One went to see a doctor, has malaria. The doctor, he complained to the patient, this is what I have, this is what I have. He finished talking, the patient finished talking to the physician. The physician wrote a prescription for malaria medication, handed it over to him or her, and then he goes and buy the medication or get it at the pharmacy, and that's it. Now, imagine that the same patients go to see another physician. The patient complains about his condition, and before the physician writes anything down, he asks questions. Since when have you been having this problem? What did you do? What was this problem? And he talk about a lot of ask questions about his home. Is your house netted? Do you have nets? Your windows are doors? Do you fleet? And so on and so forth. Do you remember having any mosquito bites? And so on and so forth. And then the physician went ahead and write a prescription for malaria medications. But in addition to that, the physicians also talk about the fact that you need to make sure that you have mosquito net. You need to, if possible, if you can afford it, net all your windows and doors. To also be fleeting your home every day. You need to avoid pool of water in your surrounding. You know, now the experience of the patient is different from one doctor to the next one. In the first one, the patient talked about his complaint, he wrote a prescription, and that's it. Get the medication. You know, for the different doctors, the second doctor not only asked about the problem for which the patient has come to see him or her, he also talked about how it happened, how did it happen, asking him question. Was your house netted? Do you have this? Do you have that? Do you plead? You know, this is medication that you will take, but please consider using net, consider this, consider making sure that your house is this. There's a difference in care. One responded to the patient's concerns with of tender loving care that shows that he not only wants to cure him of the malaria illness, but he also wants to prevent further occurrence of malaria or recurrence of that malaria. Both of them, the medication they will give naturally, potentially, will work for the patient. But one just deal with the patient for that episode of care and is gone, go and take it. The other one not only did that, but he also advised to prevent or avoid, occurrence of malaria in the future. So the patient experience will be different between the two of them. The first patient will report an experience. The second patient will likely report an experience. But I bet you the experience that will be reported by the two patients, by the patient, will be different, for the physician. So that's an example of how patient experience questionnaire is actually very, very important. Patient will come to a healthcare provider. You are qualified, you are licensed to practice, you make me well anyway. Whether I go to A or physiotherapy B, you are competent, you practice, you this, you will make me well. But if you do something extra in terms of assessing patient satisfaction with, you can see patient response can be different between physiotherapists that provide care for them. So patient experience is also part of what we will consider to be outcome that we have to measure in any care. Because this is very, very important, because we have many stakeholders in healthcare. Patient is one stakeholder. The physicians, healthcare providers that work on the patient are part of the stakeholders. The insurance companies that pays for the care that the patient receives are part of the stakeholders. The hospital itself as a whole, they are part of the stakeholders. So patient experience is very, very important, and it is one of those outcome measures that we have to develop the habit of assessing in Nigeria. I bet you many hospitals in Nigeria, physiotherapy departments, occupational therapy, wherever we provide rehab care, are we having patient experience assessed? If we are not completing care. It's not just impairment remediation. It is not just restoring function. It is actually, what is the patient experience in the course of receiving care, in this episode of illness, in my hospital, in my service, in my clinic. And that's very, very important. So patient experience questionnaire is one of those questionnaires or outcome measures that we should be using. Items include dates of visit, readings for visit, clarity of communication by the healthcare worker, listening by the healthcare worker. Are the healthcare worker answering questions? Is the healthcare worker, explaining the diagnosis or treatment options for the patient? Any information about the medications or exercises that is given for the patient, especially to carry out at home, purpose and side effects of the exercises or whatever intervention he gets? Are there enough time to discuss concerns of the patient with the healthcare provider, with the physiotherapist? Are there instructions given to the patient prior to the next visit? What about the cleanliness and comfort of the area where we provide care? Are care being coordinated with other healthcare professionals in today's days, in today's world? I talk about interdisciplinary care. Many healthcare professionals are involved in caring for a patient for a holistic care. Are there coordinations, instruction on home management, opportunity for feedback by the patient, overall experience, by the patient, and even suggestion for improvement? Patient satisfaction experience don't have to include all this, but we can select key items that are germane to the care that we provide, especially from the perspective of our clinic, of our service, of our department. So patient experience questionnaire is one of those outcome measures that we should use. I think I should emphasize that. Pain is what we measure, and verbal rating scale is one of those instruments that we use. Very simple. Verbal rating scale is common. I'm sure we are familiar with that. That's one instrument that most physiotherapists, most occupational therapists will use, even in Nigeria today. But again, I doubt the degree to which we use this verbal rating scale the way we should use them. Again, as Kikwelu et al. Found out in 2011, we are not using outcome measures a lot in Nigeria. The same thing, I believe, goes with the verbal rating scale. Are we using it now a lot better? I bet we better, but I don't think so. But it's important to emphasize that. The NETI test or outcome measure is another instrument that we use. We use it to assess gait, balance, and task performance. It needs some time to actually do that. You need like a 15-feet walkway. The time it takes to complete the test is about 15 minutes. and it is scored in a way. The maximum score for the gait component of the scale is 12. The maximum point for the balance component is 16 for a total possible score of 28. T-NETI test is one instrument or outcome measure that is frequently used, especially in subacute in the developed country. T-NETI test is a standard. It has already been built into electronic medical records in rehabilitation care. So it is important. It's not difficult to use. It is simple. And if you score the patient, again, for communication purposes, you want to speak to somebody. Technically, in many developed countries now, they will expect that, for example, an elderly person will visit a physiotherapist or relevant healthcare provider for balance and fall assessment at least once in a year that healthcare professionals will be paid for, for doing. So T-NETI test is one of those tests that you use. So if you test somebody with T-NETI test, if it's scored 19 to 24, that means there is a medium fall risk. 25 to 28 means that the patient has a low risk of fall. But if somebody scores 18 or less, that person is at high risk for fall. That means that that person with high risk for fall has to be referred for further treatment, physiotherapy, in order to prevent fall in this patient. So T-NETI test, just like I said before, in the course of evaluating a patient, assessment of a patient, we examine a patient, we risk profile them. T-NETI test is one of those tests outcome measure that we use to actually test whether somebody is at risk for fall, especially elderly person is at risk for fall or not. So it's important to be familiar with that. Sit up and go test is another test. Sometimes it is called time up and go test. It's very simple. You need a 3-meter space. You walk back and forth. The time is short. The time to administer the test is very short. 3 to 20 seconds, and then the lower the number of time they spend in doing it, the better the patient. Is straightforward, is quicker to perform, but it's not as specific as some of the gait and impairment measures that we had before. Again, sit up and go test, very simple to use. It doesn't require any training, it doesn't require any instrumentation. Use them. The sit and reach test, I didn't elaborate on that. Very, very important about flexibility. Many times low back pain has to do with low flexibility, hamstring problems in terms of flexibility. Sit and reach test, an outcome measure, many times it is used to assess the flexibility or the state of integumentary system of a person. It's important that we use them. Mini mental state exam is a 30-point test of cognitive function that is used to measure thinking ability. It is used to know a patient's stage of dementia. We can use it to screen cognitive impairment. We can use it to estimate severity of impairment. And we can also use it to document change over time if somebody has issue with cognition. All the questions, the 30 questions, are assigned points depending on their answers. The total possible score is 30. A score of between 24 and 30 shows no cognitive impairment. 18 to 23, mild impairment. 0 to 17, severe impairment. Although low score is not necessarily diagnosis of dementia or Alzheimer's disease, but use it. It's an important instrument. Mini mental state exam. In fact, in many institutions in the developed country like the United States, it's a standard. Any patient comes for treatment, for examination, or admitted to a subacute care facility, mini mental state exam is part of those tests that you will administer. Many times, it is not even the physiotherapist or occupational therapist that has administered the test. The nurses do administer the test too. Although standardly, physiotherapy also administer the test in the course of evaluation. But it is mandatory when somebody comes to the hospital. Mini mental state exam is standard for all patients, and it is done on admission. Nursing admission, nursing staff does that. But in the course of care, physiotherapist, occupational therapist will also have to administer the test and make sure that we have an idea of the mental state of the individual. especially in subacute care and long-term care facility. So again, this mini mental state exam is very, very simple to use. It's not complicated. We need it. The number that you get is a good, for purposes of communication with the physicians or other healthcare provider. Mini-Cog is another test for cognition. 3-word recall, very simple too. 3-word recall is the first one. 1 point for each word correctly recall without prompt. And then there is the second part, apart from the 3-word recall, that involves drawing a clock. So depending on whether the clock is normal, that includes number 1 to 12, and is done correctly, clockwise, you score him. And then there is also, if there is 2 hands present, that is the minute arm and the second arm, and the hour arm and the minute arm, pointing to 11, where it's pointing, you can also call that person. So mini score is another of cognition of that patient. Also very, very simple to use. There are 2 parts, the 3-word recall and the clock drawing part. Those are used. Very simple. They don't need any technical, any training, long time to so use. They are very, very important too. Geriatric depression scale, as I said, is one of those measures, self-administered, usually administered to people that are 60 and older in the developing countries. The level of enjoyment, the interest in life, social interaction, as well as more. It tests about their mood, their feelings, and their behaviors over the past 2 or 3 weeks, past week, 1 or 2 weeks, and then 2 versions, the short form and the long one, 15 and 13 question items. So it is widely used. Again, geriatric depression scale, part of the standard measures that you have to use. It is very, very important. Very simple to use. They are not elaborate. You can pull them online. You can get them. Simple to use. Please use them. DASI is one instrument that is also used frequently. What is DASI? What is DASI? DASI is an instrument that was actually coined. I'm losing energy, so I'm just trying to fix things. Yes, I'm losing power. Yes. No. Okay. DASI is an instrument. Is items that are used to. They use it to assess or estimate functional capacity, maximum oxygen consumption, and maximum metabolic equivalent of a patient, cardiovascular or pulmonary patients. Very simple to use. It's a 12-item scale. Each of the items has a score, and you score them. When the total score is more than 5, that means that the survivor of that patient is 95% in the next 5 years. That means that patient has a low risk. So it's an instrument that we use for cardiovascular and pulmonary patients, severely ill patients. After surgery or when hospitalized, they came back, we usually use it to assess their aerobic capacity. And a score of more than 5 in the 5-year survivor is very high. So that person is at low risk. A score of 4 and 11, between 4, a score of between sorry, I think I'm misinterpreting. A score between 4 and 11 indicating 5-year survival of 90% intermediate risk, and a score of 12 and above. The lower the score, this should be less. I think I'm misinterpreting this. But the importance of this is that even some of those complicated measures like aerobic capacity, functional capacity, we have outcome measures now that are actually objectify them in a different way, in form of the way the patient report themselves. It is every patient that will be able to go on treadmill to assess their symptom limited maximum exercise capacity. It is not all patients that will be able to do that, but all patients are able to complete DASI, Duke Activity Status Index. DASI, Duke Activity Status Index. All patients are able to complete that. And you can use it to estimate their aerobic capacity and their maximum oxygen consumption. Again, it's an instrument that is easy to use. You don't have the instrumentations of a treadmill that is standard. All those protocols, you don't have that. But you have that side, you can use it to assess the aerobic capacity. There are usually a formula that we use to actually estimate the MET of that metabolic equivalent of that patient. Again, it's an instrument that is frequently used for cardiovascular and pulmonary patients. We should use them. 6 minutes walk test, it's one of the outcome measures that we use. Usually require a patient for walk for 6 minutes, and the distance that is walked is noted. Again, this will be for patient that is able to walk, and there are many of our patients that are not able to walk. But if a patient is able to walk, conduct a 6 minutes walk test in order to assess the aerobic capacity. Their score is what we use, to determine the aerobic. So the distance compass is 6 minutes is used as the outcome by which changes in performance capacity can be compared over time. But you need a 30-minute walkway to be able to do that. Simple 6 minutes walk test will be for patients that are not debilitatingly ill. They will be for clients. They will be for patients that are able to walk, do the walking. But again, you want to assess the aerobic capacity. You don't want them to undergo, they cannot undergo Cooper's 1.5 mile run test, or they are above, that side, Duke Activity Status Index. You can use 6 minutes walk test to assess the aerobic capacity. Of course, graded exercise testing is the standard or the gold standard for assessing aerobic capacity. But it is possible we don't have the instrumentations in our facility, especially in the basic health centers, and in some general hospitals, we may not have standard graded exercise testing equipment, so we can use equipment that side 6 minutes walk test. But if you have a graded exercise testing, it's an important, outcome measure in cardiovascular for patients with cardiovascular disease. Just know that the terminating point will be different. For example, in patients with cardiac disease or pulmonary disease, the terminal point will be when the patient is experiencing the symptoms. I think it is important to understand this. Again, graded exercise testing is something that we standardly train our students in the university in Nigeria for a long time now. So it's something that we should be doing. But are we doing it? It's important that we be doing it. Dysfunctional breathing is one of those instruments that we use. I put this because, as I said, rehab professionals, physiotherapists, you should be able to use outcome measure to measure anything. Quality of life, health-related quality of life, activities of daily living function that are basic, instrumental activity of daily living functions, especially that limit participation. Dysfunctional breathing is one of those things, one of those diseases or conditions that we encounter in rehab. Nijmegen questionnaire is one of those instruments that we use. Again, it is used for asthma patients to test their hyperventilation syndrome. Again, it is used for asthma patients or patients that are experiencing any dysfunctional breathing, but usually asthma patients. Nijmegen is one of those questionnaires that is very simple to use. A 15-item questionnaire, in the short form now. The longer form was used before, but 15-item questionnaire that is used now. You can find them online. If you key in, go to Google, Nijmegen questionnaire, it will pull it out, and then you can see it and you can use it. Modified Rankin scale is used to assess disability among stroke survivors. It's important. Disability is one important thing that we measure too, so it's important that we be familiar with this Modified Rankin scale. It's also simple to use. The scores are there. Very importantly, rehab professionals also have to assess lifestyle. Many times we are required to assess physical activity status of a patient. Today, chronic diseases is killing more than infectious diseases other than COVID-19. We know that today chronic diseases, hypertension, obesity, hypercholesterolemia, diseases of lifestyle or affluence, they are killing people. Lifestyle or physical activity status is one of those things that we should assess in our patients. Outcome measures to use that. There are several of them, but IPAC is one of those items that we use. It's a 12-item self-report measure of physical activity scale that elicits responses of what describe a person's does at work, that is whether vigorous or moderate, sitting time at work, vigorous, and time spent vigorous or moderate, and time spent working at home. I mean, walking, not walking. I'll correct that. Is working, doing some house job. Activities at home while doing housework and during leisure time. So IPAC is an instrument that can be used to assess. It's used for population surveillance mainly. That's what it is usually used for. And it categorizes, when it is used, it categorizes a patient as either moderate or physically active or not physically active. It categorizes them like that. The APOC can be computed in two forms: in categories low or high physical activity, or in terms of MET. It can be done like that. I think, I won't go into more detail, but, you need the questionnaire. You can go online, you can pull them. Again, lifestyle is one of those outcomes that we have to measure. We assess them in our patient, and then usually after a prolonged care, maybe 1 year, if it is a chronic condition that the patient is recurring to see us, then we assess it again to determine whether there have been lifestyle changes. And it is required and mandatory for everyone, especially above 40, to make sure that they see a physiotherapist or a physician and assess their physical activity status, because it's important in order to prevent or these diseases of affluence as much. Disability is one of those outcomes that we also measure. Osweri, I talked about. I won't go into detail, but very, very important. Examine 10 everyday activities, including pain intensity, yeah, walking, sitting, standing, sleeping, sex, social travel, social activities, and travel. It assesses patients in all those areas, and it is called 100% rating. So it's available. We can use it. Very simple to use. Again, we want to assess the disability of a patient. We can use the disability index. Holmes and Rache. Boko Haram incidents in Maiduguri, an environment, in Borno State, Yobe State, a long time ago, are there going to be impact of that experience on the life of our people? Yes. People are doing a lot of things. It's hard for Nigeria at this time. Holmes and Rahi is a measure that assesses strength in an individual. Somebody will say that maybe physiotherapist, occupational, why do you need to assess strength? It's very, very important, because somebody that has stress or is stressed will probably respond to care different from somebody that is not stressed. The same thing, somebody that is stressed, the level of participation and response to physiotherapy, occupational therapy, or treatment that we give to that individual may be different from somebody that is not stressed. So Holmes and Rahi have come up with a measure to assess that. It lists about 43 stressful life events that can contribute to an illness. So items on the scale include death of a spouse, divorce, marital separation, jail time, death of a close family member, personal injury or illness, marriage, job loss. Each of these items are assigned points. And then you score a patient. Depending on the score, out of the 430 points possible, a score of 300 or more on the scale indicates high stress. This means that the person is at increased risk of developing an illness in future, not too distant. A score between 150 and 299 points indicates a moderate amount of stress. A stress below 150 indicates a low amount of stress that is bearable by every day in the course of the activity. Again, Holmes and Rahi come out with this scale, ways of assessing the stress level of the patient that we provide care for. It is very, very important as part of their life. So I want to round up now. Using measures. We want to make sure that we use measures consistently. Akim Pelueta found out 10 years ago we are not doing it. I doubt that we are doing it based on my experience with a lot of colleagues. I doubt that we are doing it, but we have to be doing it. I cannot emphasize that enough. Use outcome measures consistently. They are very simple to use. They are good, valid, and reliable. They are means that we can use to objectively communicate among ourselves, healthcare providers. They are very, very important. Our society will get to a point where you will get paid for the services that we provided that patient is getting well or not. We will get to that stage. what will make us to document whether somebody is getting well or not is not just that the patient feels better. No, it's not that. It is the outcome measures that you document for a patient, and you better make sure that you write the right thing that will determine whether you get paid or not. So, but you have to use the outcome measures consistently. We have to get used to it. We want to make sure we select what is appropriate for the condition, for the functional level, or for the setting for which we are providing care. And very importantly, I emphasize minimal clinically important difference. That is the psychometric property of an instrument is a good determinant of the instrument that we will choose to use. It is important to emphasize that in using outcome measures, we will have to use it consistently. We will have to select the one that is appropriate for that patient. We have to make sure that we select the one that has psychometric property for a patient. Again, Akinpelu's study, not 2006, but 2011, reminds us about it. Imagine there is no outcome measure. It means that our communication between ourselves, between all healthcare providers in general, may not be that coincide. It may not be that clear. It may not be that objective. And if they are not objective, they are measurable, time frame, and so on and so forth, they are not good enough. So I cannot emphasize that enough. We have to use outcome measure. It is very, very important. Questions? Questions? So I can take questions now. So am I there? I can take questions now.
Please, if there is any question, you can raise your virtual hand up, please.
Okay. Any question?
Hello, can you hear me?
Yes, I can hear you. Anike Eric Ifanye, I can hear you. Yes. I can hear you. Dr. Ifanye, I can hear you. Okay, I can hear you. I can hear you. Okay. Okay. I'm not able to hear his questions. Can somebody help me, please?
He hasn't asked any question yet, sir. He just
Okay.
said, "Can you hear me?" And we've not heard anything else from him, sir.
Okay, thank you. Okay, any other person, since we are not able to get his questions?
Hello?
Yes. Yeah.
Yeah, sorry, I want to ask in using the design measurement
Yes.
for estimating functional capacity and oxygen level consumption and all that.
Yes.
Can you please just throw more light on how we can actually use it to ascertain this measurement properly? Because that part I really want to know much about that, because
Okay.
you never took time to explain it properly. Sorry about that.
Okay. All right. DASI, Duke Activity Status Index. It's a
Okay.
measure that is an outcome measure that is usually administered on patients who are severely ill, cardiovascular disease,
All right.
especially after major surgery. What is
All
it?
right.
It's a set of items that you will score a patient in. Are you able to dress yourself? Are you able to do this? Are you able to do it? It's a set of items. Now, each of those items has a score that is already pre-assigned. Now, depending on your completing the form, you will have a number. That number will now be put in an equation. There is an equation. There's a standard equation. You will put that number in an equation. When you put that number in an equation, you will get a MET value. Do you understand? That instrument was developed and then it was validated for aerobic capacity. And the person that did the validation came up with like a conversion equation. Okay, it is that conversion equation that you will put in whatever you get in terms of the sum of score on that side. You will put it in that equation. Then when you resolve the mathematics, it will give you a number, a MET, metabolic equivalent. Do you understand it? So it is that metabolic equivalent that will now be used in prescribing exercise or know the status of that patient in terms of aerobic capacity. Again, they are items on descriptions of activities of daily living function. If the patient is able to do one activity, there is a score assigned to it. If the patient is able to do another activity, there is a score assigned to it. Like that. Now you will sum up those scores for all the activities under that side. That score, you will now put it in an equation that is already pre-developed. When you put it in that equation, you will resolve the maths, and that math will give you a number. That number is the metabolic equivalent. Do you understand it now? That number is the metabolic equivalent. Technically, oxygen consumption, we use it to determine metabolic equivalent. But you cannot subject somebody who just finished maybe a surgery to some things that will enable you determine its metabolic equivalent. He may not be in a position to do that, but you can make him answer some questions. And those questions are questions about basic activities of daily living function. Each of those questions or items has a number pre-assigned to it by the scale. Now you will now sum up based on the response of the patient. You will now sum up the numbers. That number you will put in an equation that is already pre-developed. Resolve the math, and that equation will give you a number. That number is the metabolic equivalent for that patient. That number correlates with the oxygen maximum oxygen intake of that patient. Do you get it? So Duke activity status index is not a test like a treadmill testing. It's not a test like a 6 minutes walk test. It's not. It is just a test of activities of daily living. If you say yes, you are able to do this activity, you are able to dress yourself, it's 2. Maybe it's 2. You get 2 for that. If you are not able to get yourself, you get 0. If you are able to, the list activities, remember it's a Duke activity status index. Activities of daily living, many of them, they have listed it. So if you are able to do them, you get a score. If you are not able to do them, you get 0 or not get anything, or 0 or not get anything. So you now sum up those scores on all those activities. Then there is an equation that is already pre-developed. You will then put that number, that score in that equation. When you resolve it mathematically, it will give you a figure. That figure is the MET of that patient.
Okay. Okay, I
Yeah.
can hear you very well, and I think it's very clear now. So, to be sure, I understood everything you explained.
Yes.
This particular part is talking about involving patients in some activities, maybe through questions, asking them their some functional activities they can actually perform, like
Yes.
wearing
It's not even
clothes, being
testing them
able
of
to
those
button
activities.
their.
The patient will just, you will give, it's a form. You will give the patient to fill. It is the
Yes, I
patient
understand.
I'm able to do this is cost 3. It's not even a
Yes.
test in that sense. It's a test in the sense that an outcome measure is like a test, the synonymous of the test and measure. You give him that form to complete. If the patient is able to bath himself, he will know. He will say, yes, I'm able to bath myself. There's a number for being able to bath oneself that he get. Are you able to, walk maybe 10 meters? There's a number for that. No, I'm not able to walk. So you get 0 for that. But if you're able to walk, you will get a number. So they will sum up all the numbers that you score yourself on those activities. Then the total of that score, you will then put it in an equation that is already developed. That equation, when you resolve it mathematically, it will give you a number that is the metabolic equivalent of that individual.
All right. That's a very nice one. Thank you. I'm grateful.
Yes, thank you. Any other question?
Yes, sir. Good afternoon, sir.
Good afternoon.
Thank you very much for this session. I learned a lot. Well, my question is regards the outcome measures. And
Yes.
I want to use the mini mental state examination as an example. So, I'm a physiotherapist, and one of the challenges I have is with using outcome measures here is that there's a sort of language barrier. And then, for example, now using this mini mental state examination, there's a particular part of the question that you tell the patient to count backwards, let's say from 100 downwards, or you tell a patient to spell a word. But the thing is that some of these elderly patients are not educated to that level. So if you're trying to tell them to count, how would you now get them to count? Some did not get to go to school, so they don't know how to spell particular words. Also, the language thing I was talking about, like, let's say, for example, I do not speak Yoruba, my patient is Yoruba. How will I now, like, try to translate what is written in the examination to Yoruba such that they can understand? So that's one of the challenges I have. Thank you, sir.
Good. That challenges is not, yes, thank you so much. That challenges is not peculiar to you alone. It's challenges that we face. But how we are dealing with it is that in some of our institutions, we are getting some of our students, especially postgraduate students, to actually interpret or translate those equipment. For example, in Maiduguri, one of our postgraduates was able to translate mini cog, one of the instruments, in Hausa language. So one of the challenges, well, what we will have to do as professionals is to see if we can use our institutions, universities, to actually do some of those translation and validate it. But again, as you mentioned, people that are highly educated, no problem. They will be able to complete the form. They will understand it. But people that are not highly educated, it will be tough. Remember that there are always alternatives. Mini-cog is one of the alternatives that I gave. If somebody is not able to complete mini mental examination, perhaps maybe mini-cog he will be able to complete. But one of the problems that he will have is that somebody who has never been to school may not be able to draw a clock. So that is one of the examples. Even though you ask him to look at this clock, I want you to draw it. He may not be able to do that. So that's a problem. So that's why, but I know that we have done some work in Maiduguri in doing some of those translations. So the challenge is for some of us to, in the institution, to make sure that we do those translations. Again, there are many versions of those instruments. I just mentioned the ones that are commonly used. There are many versions. If you go online, it is possible that you find some of them, that are also very useful, that are not that can be adaptable to people in our environment. But again, thank you for mentioning that. It's a challenge to everybody. But on our part at the institution, we are trying to translate some of those equipment I know we did that in Maiduguri for many mental state, I believe, to Hausa, and then we did some of those and even validate them as much as we can. So that challenge, I will report back to my colleagues in the universities. Let's make sure that we have many of those instruments converted and validated for our local use here. So thank you so much.
Thank you very much, sir.
Yes. Any other question? So the key takeaway here is that the instruments are very, very simple. All of them are simple. Don't be intimidated. Very simple. Once you begin to use it, you will get used to it. They're very simple. Numbers you can record, report, good for communication. Very simple. They are not complicated at all. There are many, many versions that you can use. Just make sure that we begin to use them frequently now. Again, as I said, in the New Hope agenda, they are transforming healthcare, whatever that means. We need to do better on our own part as professionals with skills to make sure that we help the government to achieve what they want to achieve. And that is by doing what we have to do. Part of the job is to be using those instruments. Part of our job is to make sure we translate some of these instruments to our own local languages so that people that are not educated or that numerate may be able to use them. So I think I cannot emphasize that enough. We are not using outcome measure. A decade ago, Akinpelu et al., they did a study, we are not using it. My experience with postgraduate students, even up till now, we are not using it. Go to most facilities, check their charts, check their notes. You will not see them using outcome measure. We need to be using it. It's very, very important. It's a language of communication. It's good for the patient. It's also good for us. And importantly, too, we must not neglect the fact that patient satisfaction is part of the outcome measures that we need to begin to use. Dr. A, Dr. B, physiotherapist A, physiotherapist B, they took care of patients. One can be better. All of them, licensed, trained, they will make a patient good, better. The interactions, patient satisfaction is also very, very important. It's an important outcome measure that we must be using. I think I need to emphasize that. Very simple to use, all the instruments, very simple to use, not complicated. The more you use it, the more you get better at using it. I cannot emphasize that enough. Please, let's use it. Again, they are available online. Just Google any of those instruments, you will find them, and pull them, you can use them. Again, finally, on our part in the institutions, we will try as much as possible to work on the translation. I'm aware that about some of those instruments that have been translated now. We have our version of IPAC now. We have our version of IPAC that we have done in Maiduguri, and we have it in place there now. We have a number of instruments that we have actually translated, and they are useful. So any question? Any other question? Disability is an important outcome measure. Physiotherapists are usually the ones that are asked to actually determine the level of disability of a patient or somebody. Is he able to return to work? If he's not able to return to work, we want to compensate him. What is the level of disability? Low back, other disability, other problems. Therapists are usually the one that they will ask to actually rate the disability. You need to be able to use the outcome measures to do that properly, in addition to other things. I think I cannot emphasize that enough, please. Again, if there are no other questions, I want to apologize one more time for the delay. I dozed off, and so I apologize one more time. But I hope you enjoyed the lecture. Thank you so much. Again, if there is no other questions, I think my own lecture ends now. I'm still going to be online. Dr. Ojetunyibo will come. Perhaps we need like a few minutes break to cool off, and then we come back. I leave that to the discretion of Dr. Ojetunyibo and the Dr. Lu. Somebody is entering. Yes.
Thank you very much, sir, for the presentation. Sir, please, with crave your indulgence, I've sent Dr. Ejetoyinbo's presentation to your mail. She's actually having a challenge sharing it from her hand here. So would actually appreciate if you can help share it, sir.
Okay.
Thank you, sir. Right. So we can just have like about 10 minutes break.
Okay.
Then we'll come back. Thank you very much.
All right. You're welcome.
Yes.
So let me see. Should we stay on, or let me see if I can just. Should we stay on, or while I pull it up?
And we can wait. Well, I've given a 10 minutes break. So while you're trying to pull it out, we can be waiting, sir. Thank you, sir.
I don't have to log off too. I can just, let me see if I can pull it out. Dr. Tulu, is it showing now? Okay, I'm trying to, I want to stop sharing. Is it there? Is the presentation there now?
Not yet, sir.
Not
your
yet,
screen is,
okay.
you've not started sharing your screen yet, sir.
Okay, I have this. Okay, so let me. Okay, I'm coming.
Prof, sir, any progress with it, sir?
Hello, good morning, Prof. Good afternoon. Good afternoon, Dr. Solu. I think where you had an issue, Prof. Never exited his sharing. That was when you are trying to share, and that was why you couldn't do that. Allow Prof to exit so that then you can share from your end, or the presenter can share from her end. I think that's where okay. I think that's where the problem is. Because if
He has
he
been
then
able to share
started.
now. Prof can now share
Okay.
now. Thank you, sir.
Okay, so no problem. Okay, thank you so much.
Prof, sir, we cannot see your screen anymore, sir. Please, sir, we cannot see your screen. Okay, we can see it now.
Okay. All right. Let me see. I want to go to the share now.
Okay.
Are you seeing it now?
Yes, sir.
Okay. All right. Okay. Yeah.
Okay, Dr. Jetoyinbo, ma, I think you can start up, ma. You can kindly unmute, ma, and start up, ma.
So I will project for her, right?
Yes, sir. Dr. Jetoyinbo, ma, please, ma, kindly unmute, ma, and speak, ma.
Can you hear my voice now?
I can hear you.
All right.
Yes, ma, we can hear you now, ma.
All right.
The floor is yours, ma.
Okay. Good afternoon, everyone.
Good afternoon.
I stand on existing protocol as I present Part B of today's course title, Evaluating Progress Towards Desired Outcome. Therapy outcome measures are an essential tool in the field of rehabilitation professions because these measures provide valuable insights into the effectiveness of therapeutic.
We're not looking at the same page. Sir, can you go back a bit?
I'm only talking not on the slide. This is the first slide. I think, okay, you can go back to slide 1 now. Go back to slide 1. Okay, as I was saying, therapeutic intervention, they can help to track clients' progress over time. World Health Organization 2030 agenda focus on this group and giving understanding and implementing the therapy outcome measures. And this has become increasingly important for both practitioners and clients. So it is objective indicators to change. It is objective indicators to change. This, my slide, this subtitles, I will explore the therapy outcome measures we discussed and consumable relevant to scope of practice. It's the first one. Then implementing, inspecting, measuring and testing techniques. Later to go to scoring standardized outcome measure. Then to interpreting the results of outcome measure. And then assessing body functions, activities, participation through observation and interview. And it will end on evaluation outcome. So, as a seasoned rehabilitation professional, this lecture will provide valuable insights into the evaluating progress of desired outcome in your practice. Now to start with slide 1. setting up and using equipment and consumables. Opening a place to practice is an existing and rewarding venture, but it also requires careful planning and preparation. I want us to know that one of the most important aspects of setting up your practice is choosing the right medical equipment to meet your needs and standards. As Professor Yemi described, the scope of practice to be the services that a qualified professional is incompetent to perform and permitted to undertake in keeping with the items of their professional license. So being an audiologist, my presentation will dance around audiology profession. So how can we set up and explain the using of audiological equipment and consumables? To start with, they are classified as follows. The equipment and consumables under rehabilitation medical services are classified as follows. We classify them to be the basic essential equipment and consumables. We classify them to be specialist equipment, and those ones are referred to as advanced equipment. We classify them to be under software and hardware. They are classified to be cleaning and disinfectant equipment and tools, while the last one is on emergency items. So to talk about the basic diagnostic tools and consumables, this first category of equipment, they are the vital signs monitors. They are the consumables and the equipment that are very cheap, that are not inexpensive, but must be available in all our clinics. Such are eye scale, thermometer, wind scale, examination couch, exam table and chairs, lighting, trolley, medical tray, otoscope. To mention all of them, there are plenty. The list is inexhaustible. Consumables are syringes, needles, speculum, tongue depressors, mask, cotton wool, methylated spirit, gloves, lancet, that is for blood, taking blood sample, swabs, cannula, sanitizer, comfortable chairs and table for examination. So we have them to be getting all these ones. It will not delay our procedures, and it will consider purchasing a variety of them. So it will not be what we go to market for every week. With all this, the health care practitioner can provide quality care, and all these are essential for providing safety and effective care to the patient. And as we are setting up equipment, those that are comfortable, versatile, and thorough are those ones that we should consider. Likewise, so important to maintain a safe and hygienic practice environment. It will empower the practitioners to make timely and informed decisions, leading to better patient outcomes. So we still have specialist equipment. These ones are the equipment that can only be handled by the expertise. They are equipment that we need to provide specific services to your patient. It's not to be, and you can't find them in all the hospitals, in all our clinics. Not all of them are available. In most of our clinics in Nigeria here, they are sophisticated and expensive, but they are most valuable to diagnose and manage certain conditions. So in audiology, it ranges from screening equipment to diagnostic, even down to rehabilitation setting. It may not be available in all health centers as I've said. Then neonatal hearing screening is one of those procedures that we may need such equipment for. It's part of electrophysiologic equipment, auditory brainstem response equipment. All these ones, they can come in modules, they can come with other modules, and it will give comprehensive evaluation to both to all the categories of the patients, starting from neonates, infants, uncooperative adults. So this specialist equipment, if I want to lay more emphasis on what we do in audiology, we have a lot of them. The list of them is long. Look at hearing rehab laboratory. It can be fun. Hospital. You can find maybe 1 or 2 hospitals in Nigeria to have hearing aid analyzer, hearing sound chamber, the text box laser, the impedance meter, the spectrum analyzer, hearing latest software, hearing lab supposed to contain. But also we have vestibular management equipment as well. Equipment, infrared goggles, electromyography equipment, all of them are the specialist equipment that can be only handled by the specialists. So other rehabilitation professionals as well, there are many of these specialist equipment. So as it continues, you can see how this slide explains those specialist equipment under audiology, starting from sample booth, otoscope, audiometers, tympanometers, autoacoustic emission equipment, transducer bone conduction, calibration tools, sound level meter, masking equipment, hearing loss simulators, and echocochleography, together with ABR equipment. And while we should consider for other professionals, we have respiratory therapy equipment as well, LASA equipment, assistive mobility equipment, electrotherapy, heat and cold therapy modalities, wheelchair and welfare, and the worker, therapeutic beds and mattresses, the therapy benches and tables, voice analyzer, pitch analyzer. All these are the equipment that are to be used specially by the specialist for advanced procedures in rehabilitation settings. Overview of the importance of proper equipment. It is crucial in various fields, including healthcare, research, and industry, because of what we derive from it, as it ensures accuracy and reliability. It helps to maintain safety. It optimizes performance. It reduces errors, saves time and resources. Having all these basic and essential equipment and consumables will help to gain access to the lifespan of the patient, and equipment will help to ensure data integrity and promote user confidence. Setting up equipment is a step-by-step guide. It's not what you can do at once. It's a step-by-step guide. To start with, there's what we call pre-setup checklist. The setup checklist. This is the checklist that entails all you need to know, all you need to see about the equipment. To review the safety protocol to ensure necessary tools and materials that are available, the component that comes with the equipment. So it verifies equipment packaging. After that, we move to unpacking and inspection. To every equipment ordered or bought, you first of all carefully unpack the equipment. You must carefully unpack it so it will not cause damages to the equipment in the process of unboxing it. Inspect this equipment we are talking for. You need to inspect it visually for damage. Has anything wrong with it in the process of packing or sending it? You will look for its defects. That will be service defects. You verify completeness of components, all these components. Carefully unpacking it, there are lots that you need to look into. You will remove equipment from packaging materials. You will identify components if they are complete. If it is what's supposed to be there, it's what you are seeing you're getting. Then recognizing and labeling individual parts as it shows on the checklist. You verify completeness of components. Then you follow the assembly instruction of it. Not only that, you still recognize the labeling individual parts of the equipment. While you are setting up your equipment, there are many things you need to do. You will read and understand manufacturer guidelines very well, so there will be no misappropriate of the function in the way you put them together. Sequencing assembly steps correctly must be followed. Connecting parts according to instructions. You have to ensure secure and proper connections as well. Final check must be done. And when you are doing this one, it will give you best practice. Handle equipment with care to prevent damage. You use necessary tools and materials to assemble it. You follow manufacturer instructions. Double check assembly for accuracy. Test your equipment before you use. That's how it's supposed to be when you are unpacking. And when you are trying to ensure safety features, you have to review safety manual and guidelines as well. You need to identify safety features, the emergency stop, the alarms and warning that could have been put there, your protective guide, your interlocks. You have to enable safety features by activating emergency stop, setting alarm thresholds. You have to install protective gas and then configure the interlocks. Testify, you have in the equipment that you are setting up, you have to verify emergency stop function correctly. In case anything happens, that is where you will go straight. Testing safety features will still help you to check alarm responses to ensure protective guides as well. And it will help you to perform maintenance tasks. So when you are doing this one, you follow manufacturer instruction to set up. You will train users on safety feature operation if you are not the only one to be handling the equipment. Regularly review and update safety protocols. It will help to ensure safety features as well, and then document safety feature testing and maintenance that you could have done. The completeness part of it, you have to check packaging and shipping documents. It's about visual inspection. It's about component count. It's about checking for accessories. It's about verifying component labels and marking. You have to verify the software and firmware that will have been attached to the equipment. Check for certifications and compliance. By following all these steps, you will be able to ensure all necessary components are present, they are accounted for, and they are ready for use in installation. Setting up and using equipment in audiology. It will involve having a sample booth. And this year, sampling minimize external noise and sound reflection. It is a place where you keep your patient. So you must see to the comfort of your patient. It must be away from noise. Shield the bag, shield the sample and the equipment place away from noise. from too much noise. Background noise, maintain a consistent low-level background noise. Anything less than 20 dB hearing loss will be appropriate for the place of sound proving. Check the temperature and humidity to reduce the patient's discomfort. Then lighting is important. Don't make the place dark. Electromagnetic interference, you need to minimize it from devices, something like a cell phone, radio, or fluorescent light. Patient comfort is very, very important. Let's ensure that our patients, they are relaxing, using comfortable seating and minimizing distractions. So when you are doing all this to set up your equipment, don't forget calibration part. Every equipment must be well calibrated before use. It will ensure accuracy. Then acoustic considerations as well, including reverberation time and sound reflections. You need to minimize all this because it have impact on the test results. Then standardized testing protocols. This will help us to ensure consistency and accuracy as well. Quality control must be considered as well. That is regular access and optimize the test environment to ensure high quality test results. So if our test environment is well optimized, audiology can assure accurate and reliable test results, which are essential for proper diagnosis and treatment of hearing disorder. As we can see the picture of environment on this slide, the environment for audiology must be placed on designated areas. As I said, we have to label all what we are using, all the items there. Then it must be safety. It must be safe for our patients. Safety must be sure of. There must be all these safety features on ground, the emergency exit, the fire extinguishers, all this must be on ground in case anything happens. The cable must be well managed. Our cable must be well managed. I have a diagram here to show. Okay, we can see that man that is carrying out hearing test on a woman. If everywhere is well conducive for the patient, and that is where we are going. The woman can sit comfortably to say yes or no if you can hear. This is like the slides are not stable. Okay, so the woman can sit comfortably. The cables are well arranged and organized equipment. The environment is conducive. It must not be too cold. It must not be too hot. Noise must not be intervening. So we can see when the visual otoscopy is doing, see how the cables are well arranged, including the video otoscope. So you need to handle cables properly. Avoid bending it. Twisting of the cable can affect the results. Let's keep the cable organized. Let's store cable properly. We can label our cable to know which is which. So you not go and put the bone conduction cable for the air conduction cable. I will not put the red on the left and the blue on the right. So avoid pinching or crushing of the cable. All this will help the accuracy of our equipment. The next ones are the equipment, different audiometers that are placed there. When you are setting up equipment, it depends on your motive, on why do you want to As we are seeing audiometer can be audiometer as an equipment. Which particular one do you need for a particular purpose? If you are to use it for conservative reason, you need the one that will have a range of frequencies from 120, we call it extended frequency. Their frequencies will be more. It will be the equipment that we have plenty frequencies to measure for conservative purpose. And for screening, you can use any PC equipment, audiometer that have the communication frequency. So for diagnostics, you can use diagnostic particular audiometer. That means when you are talking about setting up hearing loss clinic with equipment called audiometers, let your motives be well defined for you to know whether you are buying, monitoring audiometer, diagnostic audiometer, screening audiometer. As you know that screening audiometer may not necessarily have a bone conduction vibrator. So setting up equipment expands to how much procedure, how many procedures, how much patient do you want to see? What are the categories of your patient to see? Some in abroad, audiology have been specialized on different areas. We have pediatric audiology, those that are attending to old people. We have a pediatrics audiologist. We have a industrial audiologist, and so on and so forth. We have school audiologists as well. So in setting up equipment, let the particular equipment you need be your target. Like we are seeing here, it starts from ordinary screening from the conservative tool down to using of the modern equipment like soundproof to carry out your soundproof booth to carry out your test. If you want to extend, you can still extend to have a tympanometric procedure, then down to where you do screening, common OAE screening, one channel screening for the neonates, or where if you want to expand it to where you'll be doing 2 channels as well, using the auditory brainstem response equipment and the autoacoustic emission battery as well. You can extend it to the use of vestibular apparatus, vestibular equipment as well. And in your clinic, it is not bad to put all these labels, the posters that will reflect what you do. Like it happens one day in my office as I was sitting, my CMD just entered unnoticed. And the first question he asked me, I knew he wasn't aware that such office is existing. The question he asked me was, sorry, how come you have a typing pool of your own? Because he expects 2 or 3 people to be in a place as a typist or the secretaries of the hospital. I said, sir, can you please look up? Because on the wall of my sample booth, I put some posters that shows some of the audiology procedures that we do, or some of the pictures that relate to audiology profession. So say, wow, sorry, I'm sorry, I didn't look up. So that's how it's supposed to be. You're setting up equipment place must show what you do. It must reflect what you have to sell to people. Place your equipment accordingly based on your motive and your target patients. So the third category of the equipment and the consumables that we listed in the first slide is about software and hardware. Taking it to digital level, when you are synchronizing all you are doing is computer. It will help you to have access to electronic health records software. You know, people are no more carrying case notes up and down any longer. And it will allow easy patient data management. It's a user-friendly software for efficient scheduling. These are to be used to manage practice, administrative, and clinical function. They're enhancing the productivity. And it improves communication and complying with regulations. So such items are those ones that this picture shows. We have desktop, we have software, we have hardware, we have all the accessories, we have fax machine, software, programmers, we have billing codes, electronic, health records, and the like. So my advice to you on this is that choose those that are user-friendly, that are secure, and up to date. So when we continue with using of equipment, you can diversify the way you want it. There are some of the procedures of audiology that are not, they're not, incorporated into other, they are singly treated. Like if you go abroad, you can see many offices, many signposts everywhere. And they say tinnitus treated clinic. Then this one may call his own ear wax removal clinic. Another one will say vestibular clinic. Audiology has a very long hand. We can stretch it to anywhere. So using equipment, make sure you buy, you purchase, and you set up the correct equipment that's meant to do what you intend to do. And we are on the results also, we can produce it in different forms. Some through thermal paper printed, and some to be manually produced. But mostly these days, in this current age, most of them are produced digitally. And these are the samples. In case you see all these jargons, you may be asking, how come we have all this in audiology? This is the pattern spectrum. This is an audiogram. There are different kind of, all these ones must look into what you need as equipment or accessories or consumables to get them ready after carrying out the test for your patients. Not to be biased, physiotherapy clinic, they can have their own clinics to be well equipped in this way, well arranged, well organized, to be to have safety feature, to be labeled according to their usage. So physical therapy, if you can have clinics like this, it will encourage the patient even to patronize us, to come around us. They will feel comfortable each time they are with us. So to the speech therapy clinic, at times I will enter some speech therapy room, I will be amazed seeing only paper, ABC, carton, toys, and the like. There are many other equipment, useful equipment that can as well be recommended to that sound analyzer, voice analyzer, all this can be useful. Fluency machine, all of them supposed to be part of equipment to set up for speech therapy to be running effectively. The fifth part of the category is about cleaning items and equipment. This one, clean and of your patient. So they are crucial for preventing spread of infections, especially where you are attending to neonates. Even adults, We have to ensure the quality and longevity of other equipment as well. For example, when you are using tympanometer with the probe, if care is not taken and you have not carried out your otoscopy, probe will be clogging out the wax, the cerumen in the ear. And the process, if you don't disinfect, if you don't clean it, you will still use the same probe for another patient. It's easy to transfer disease, to spread infection in that way. So there are items that you cannot mention all of them here. You should choose the ones that are eco-friendly, that are sufficient and effective. Just ensure you have adequate cleaning solutions for infection control. We categorize them to be in two forms here. We have all-purpose cleaners, where you see all those simple and things that you are seeing around, like detergents, disinfectants, sponges and scrubbers, mops and buckets, broom and dustpan, vacuum cleaner, and you can see as well have specialized cleaning. Those ones are the sterilizers, autoclaves, electronic cleaning solution. You know, there are many ultrasound scanner, cleaner. They are all there for us to have. We must consider them, having them around where we are working, so we will not be running up and down when the needs arises. So also to number 6, which is for emergency. For emergency, there are certain things that should be among what we have in our clinic when we are setting up things like a functioning machine system responsiveness, and it involves an effective procedure. Functioning machine should be available. Fire extinguisher, oxygen cylinder with gas. Always make sure that your cylinder has gas. You can never tell what can happen. Smoke detectors as well, touch protectors, UPS. So where you have started, you will not go back when the Nigerian NEPA sees light. So these are the goods to protect your practice of fire, power outage, natural disaster, or other potential hazards. Just ensure you choose emergency backup that are compliant, accessible, and functional. And so on and so forth are the list of consumables. They are used. Some can be disposed, some cannot be disposed. Audiologically, you must have probe tips and covers. You must have batteries and power source. All these probe tips, at times, if the probe breaks to get extra may cost 2 years. In this all our federal government hospitals, it's good to have access of all these ones. It's good to have all access. You can have all medical supplies around, like gloves, masks, gowns. All these consumables are very, very important. World Health Organization 2030 agenda relating to rehabilitation equipment acknowledges the profound unmet needs in rehabilitation service, because all these that I've mentioned, both in equipment and in consumables, cannot be all found on your desk, cannot be all found on my desk, cannot be found in most of our hospitals in Nigeria here. And the World Health Organization, part of the agenda is to address the global shortage of rehabilitation equipment and services, especially in low and middle countries, and to promote accessible and quality rehabilitation service worldwide. That is when we are talking about GATE, that is global accountability technical heat. So talking about people, policy, product, provision, and personnel that will be involved before all these things can be well achieved. So these are the pictures of consumables. As we have medical consumables, so we have office consumables, and we have clinic consumables, and all other ones around here. All are supposed to be around us. We're supposed to have all of them. So what are the importance of proper setup and use of equipment and consumables? Why is it important? It's important because of accuracy. because of safety, efficiency, quality control, because of compliance, cost effectiveness, because of the patient care, because of user protection, environmental protection, and research integrity. So this is the second slide, and it's talking about implementing, the second subtitle, and it's targeting, implementing, inspecting, measuring, and testing techniques. You have to implement your inspecting, measuring, and testing techniques. Before you start, what is inspecting? To inspect is just to identify defects, deviations, or non-compliance that can impact the quality, safety, or functionality of item being inspected, whether the equipment or the gadget or tools or instruments that you need to use. You have to inspect, to detect any defect that will be there. And you can do this one through direct visual inspection. That is when you are using your naked eye to examine material. It is the simplest and most straightforward method anyway. It's old way, but at the same time, it is valuable. It's exams of equipment and process of record. So you can still check documentation under inspecting. When you are inspecting, you can verify specifications, certifications, even maintenance records. When you are inspecting, you can use inspection tools as well. And in audiology, we inspect by visualizing the ear canal. That means the tympanic membrane of the patient. When you are trying to visualize it, and you can use a otoscope, because your height may not be able to go far, but some people mere pulling the air back and upward using the height. If there are foreign bodies, it's easy to see. But now that there's an otoscope, it's better we use otoscope to inspect. So inspection of hearing aids as well is good. That's where you know where the battery has expired, the coil, and other components. You can easily see where the problem lies. It's not functioning again. Then checking patients' records and test results. All this we can get through inspecting. Inspecting techniques are there. Sensory inspection. You can use any of your senses. That is visual, auditory, tactile, and olfactory. Performance evaluation as well. You can use functional testing, performance testing, efficiency, accuracy, and speed. Also, technique of inspecting is non-destructive testing method. When you use thermal imaging vibration analysis, then destructive testing purposely damaging equipment to test its limits or failure points. Measurement and alignment check as well can be done. Specialized testing also is part of techniques of inspecting, and advanced diagnostic techniques when you are still carrying out sensory inspection. The second concept under this subtitle is measuring, and is about knowing the quantitative evaluation of performance, accuracy, and precision. So selection appropriate instrument. You have to select appropriate instruments, to choose instrument that is suitable for the measurement task. Calibrate instruments so you will be sure of accuracy of the results. Then take precise measurements also to follow the instrument. In so many professions and fields, there are measuring techniques, different ones. This is the list that I may not be able to run through because there are many. But specifically, I can mention it under audiology that PCA can measure hearing threshold. Autoacoustic emission helps to know cochlear function. If the cells in the inner ear are hindered in the outer ear, evaluate middle ear function, and auditory brainstem response testing also helps to evaluate neural responses, so speech recognition. Examples like a spectrometer, analyze material composition of properties, thermometers can as well be used in other fields, in other professions. So the third concept is testing. The third concept is testing. And testing is about validation. It's about validation of equipment. It's about validation of equipment, process, and patient outcomes. When you are testing, we develop test plans. We create test plans that we outline objectives, procedures, and acceptance criteria. When you are testing, you need to conduct tests, execute tests according to plans. You need to use suitable equipment and methods, analyze results. Evaluate test data to determine either pass or fail. Then we identify area of improvement. So these are the testing equipment. When you are testing, you need to test technically through the unit testing, the one that we verify individual components or function. Integration testing, that's when we test how components interact. And system testing, it will point towards evaluating the entire system. Acceptance testing, it will help in verifying the system meets requirements. Security testing, usability testing, exploratory testing, automated testing, all these ones, gray box testing, combination of black and white box, all these ones are the testing techniques that needs to be implemented in our practices. Now, when we are to implement inspecting, measuring, and testing techniques, how can we do that? We can do it by defining inspection objectives. You have to clearly determine what you want to achieve. If we are implementing inspecting of measuring of testing techniques, we need to define inspection objectives. Choose appropriate techniques. You have to select the technique to use. You have to develop an inspection plan. You have to develop an inspection plan. Train personnel that will be involved in helping to inspect or measure or testing must be trained towards that goal. Gather necessary equipment. You have to collect required tools. Conduct the inspection. Analyze the results and report findings. All this must be done. How to do all these ones can be illustrated through audiology practice. As I said, when you are inspecting, visual inspection of the ear canal and tip membrane, otoscopy to assess ear canal, visual reinforcement, audiometry, that one can be used to carry out audiometry for the pediatric assessment, can be used for pediatric assessment. And for measuring, pure tone audiometry, we measure hearing threshold. Speech audiometry, we assess speech recognition. Imitance testing, that will help in tympanometry and acoustic reflex to evaluate the middle ear function. Also, acoustic emission, we help to assess cochlear function.
So,
And
sorry,
ABR,
excuse me, ma. The background noise from your side, is it a television you turn down or there are people around you? It's really distracting, ma. Sorry, please.
Wow. And it's very, very hard to hear you. Okay. I'll tell them, please reduce the volume. I beg. Go and help me to tell them to reduce the volume of their TV. Sorry about that. So, as I was saying, testing. In testing, when you are testing in audiology, you consider behavioral observation and auditory skill assessment, speech in noise testing to evaluate speech recognition in noise, and then auditory processing disorder. That one will help to assess APD. So vestibular function test, electronystagmography and video nystagmography can be used as tools for testing. While tinnitus assessment and management also have what to use for the testing. So audiologists may use questionnaire and surveys to gather information about symptoms and communication abuse. And they can as well use acoustic analysis software. So audiologic equipment that is well calibrated and maintained will ensure accurate results. So by implementing all these three techniques, that is inspection, measuring, and testing, audiologists can accurately diagnose and manage hearing and balance disorder. Then develop effective treatment plans, monitor patients' progress and outcomes, and as well be able to enhance patient care and communication. You will be able to stay current with best practices and advancements in audiology. And to implement measuring techniques, so many steps that I said is the same steps that will be done under testing and inspecting. There are some reasons why we must implement this. One is to ensure consistency. There must be consistency in the results that we are producing, in the results of the hearing. Standards and procedure ensure consistency in implementation. That is to reduce errors and variability. And it will still promote quality. It will help in enhancing efficiency. It will help to reduce risk. That is when standards and procedures mitigate risk by identifying potential issues and provide solutions. So it will support accountability. By following established procedures, accountability will be transparent. Encourages continuous improvement as well. So review and updating standards and procedures will drive ongoing improvement. There are certain things to put into consideration when we are doing this implementation as well. There are certain things to put into consideration. And one of them is to patient preparation and counseling. When you are preparing your patient, you just have to explain testing procedures and purposes clearly. Let's be sure that the patient understand the instruction. Ensure patient comfort and relaxation. Then minimize distractions around the test environment. And as well prepare necessary equipment and materials for the patient. So in the aspect of the counseling, you have to educate patients about their hearing and balance condition. You have to explain test results and implications to the patient. When you explain to them and they have better understanding of what happened or what their ear status looks like, it gives them a soft problem. You have to discuss treatment options and recommendations with them. You have to address patient concerns, because when the patient enters, it should be part of our clacking questions. What exactly is your concern? It's not about bringing him the referral sheet or whatever to come for. No, what exactly is your concern? From there, you'll be able to provide information. From there, you'll be able to understand whether you have already met the needs of the patient through your counseling. So additional consideration is about patient-centered care. You have to focus on individual needs and preferences. You have to adapt counseling to patient cultural background. That's another area. You have to use clear language to provide interpretation services if needed. Then you have to show empathy and understanding to the patient as well. All this will help to know that aspect of implementing what you have achieved from inspecting techniques, testing techniques, and the measuring techniques. The next subtitle to consider is scoring standardized outcome measure. Scoring standardized outcome measure. From here, we will first know what is standardized outcome measure. And first of all, understand, with regard to the process of identifying to evaluate the quality, the performance, or compliance of patients. That is when you are trying to track progress and evaluate effectiveness. So, what exactly is the purpose? The purpose is to evaluate quality, to evaluate performance or compliance as well, and to provide a quantitative measure of achievement or deficiency, and to enable comparison and ranking. You have to identify areas of improvement. It's through your course to be able to have all the information. So standardized outcome measures, they are tools that are used to assess and evaluate the effectiveness of what patients, the effectiveness of intervention, the effectiveness of treatment, the effectiveness of programs. They are commonly used in clinical practice, in research, and even in healthcare setting. So, what does it help us to do, to understand, or what are benefits do we derive from using it? It helps to evaluate treatment effectiveness. It results whether this you are doing, this treatment you are using for the patient is really bringing out results. You'll be able to monitor patient progress. Be able to monitor patient progress. You will be able to compare outcomes across populations. So many patients we have seen within a particular period using the same method, the same procedures, the same treatment. Where and where are you biased? Where and where you're supposed to consider certain factors that you don't consider, and what is the result across all of them? Informed treatment decision will help inform treatment decisions, and it will help support evidence-based practice. So when we are choosing all this one, we need to remember to choose measures that are reliable that are valid and relevant to your specific population and goals. So this is the example of standardized outcome measure. We have so many of them. We have about so many uncountable ones, but I just pinpointed about 10 here. Likert scale. You can use Likert scale, point scale. You can use visual analog scale to measure. You can use numerical rating scale. That one is 0 to 10 scales, that's to assess pain, fatigue, or other symptoms. You can use standardized questionnaire. That one is called system for validated questionnaire, like the SF236. The format to it to assess the stability of the arm, shoulder, and the hand. Functional assessment. That is when you are scoring a system of evaluation, like the functional independence measure or the third balance scale. That is one we call BGC. So goal attainment scaling helps to customize skills measuring progress towards individual goals. This one is what they call a GAS scale. GAS scale. So we have percentage change one. This one will help to calculate percentage changes in outcome measures over time. And standardized response measure will also help to calculate the mean change in the outcome measure when it is divided by standard deviation. So minimal clinically important deviation, this is MCID. It helps to determine the smallest change in outcome measure when you use it to consider clinically. There are many of these standardized outcome measures. This scoring method will help to rehabilitate professionally as we quantify patient progress and we evaluate treatment effectiveness, then inform data-driven decisions. For example, if you ask the question of, are you satisfied, very dissatisfied, somewhat dissatisfied, as the scores have been assigned to each question. Very dissatisfied with a score of 1, somewhat dissatisfied 2, neutral 3, somewhat satisfied 4, very satisfied 5. Instruction. Just choose a number from 1 to 5 that best represents your level of satisfaction. Those are the kind of instructions. These are the kind of form, the kind of standard outcome that you see in Likert scale. So they are versatile and widely used in healthcare research and customer feedback survey. So about the GAS, that has its own format as well. It has its own format as well. If you talk about the scale of A, that is 5 points. Progress towards goal. -2, that will give us significant regression. 1, no progress. 0, maintenance of baseline. 1, expected progress. Each one can be used to measure the score. They are all standardized outcome measures. The explanation about that still continues because its benefits will help us to centered and goal oriented. And it made the course to encourage collaborations and communication agreements as well. It will provide clear and measurable outcomes, and it will help to support evidence-based data. So these are the key description of that. That is the goal attainment scale. It is very specific and measurable, as Professor Yemi just mentioned, part of what all these questions to have as attributes. It's achievable, relevant, it's time bound, collaborative, very focused on outcomes, it's sensitive to change, easy to use, valid, and reliable. So if you incorporate this gas skill into your scoring, it will help to achieve goals in 0 seconds and participant score. So typically in audiology, when you have the total score, you have to calculate averages, you have to convert raw scores, that is transforming raw scores to standardized scores. You give percentile score. You have to interpret your cut-off score, like when you are looking for the threshold of variance divided by 3 that is accepted conventionally. You have to compare the norm, that's comparing individual scores to age-related ones, and you can track change over time. So these are the guidelines for audiology outcome measure. The specific scoring guidelines. You have hearing handicap inventory for adults. You can score from 0 to 100, and interpretation is either higher score indicates greater handicap. Go to tinnitus testing when you are scoring tinnitus and use tinnitus handicap inventory. Before on the sum of rating, that is 0 to 100 as well. And interpretation will be higher score, which will indicate the higher pitch tinnitus perception that the patient may have. And dizziness handicap inventory, you can use VHI for it. You can score from 0 to 100 as well. And interpretation can still be greater handicap. So for cochlear implant and for quality of life, there's a scale for it as well. And the scoring with the average of rating, that is 1 to 5. And interpretation will indicate better quality of life. So to speech recognition threshold, the scoring will be from signal to noise ratio in decibel, and lower scores will indicate better speech recognition. So concept of the specific outcome measures manual and guidelines for detailed scoring function and interpretation. This is for the audiology. And the services will involve assigning numerical values. When you are assigning numerical values to patient assessment, you are trying to track their progress and evaluate assessment. These are the examples of what we do and how we go about doing the scoring. The pure tone audiometry, that one we call hearing threshold in decibel, and it will determine the level and the type of hearing loss that an individual has. So speech recognition score calculates percentage that is correct for speech recognition. So that is if you calculate the words or sentence that is recognized by the patient. Speech in noise test, this is a signal to noise ratio scale. It helps to assess speech understanding in noise. You can score through hearing handicap inventory. This scoring will help to report the hearing handicap level of an individual. So cochlear implant outcome measure also scoring speech recognition, sound localization, and music perception as well on the score. So auditory skill development is another area that can be scored. When you assess progress in auditory skill, the touch detection level, the recognition level, and localization level, and patient satisfaction questionnaire. That will help to score length-oriented scale of improvement, quality of life measure, evaluating implant. When you're evaluating the impact on the quality of life, you can use the Glasgow benefit plus on the health utilities index. Another one. These scoring methods help audiology professionals to quantify patient progress, as I said, and it evaluates treatment effectiveness and inform data and decision making. And about the tinnitus as an aspect in audiology, if you use tinnitus handicap inventory, if you measure the tinnitus related distress and disability, all the comorbidities that are attached to tinnitus problem will be scored. Tinnitus questionnaire, we assess tinnitus severity. How severe? Is it the high pitch tinnitus or low pitch tinnitus? The score will be within 0 to 100. Also visual analog, and so tinnitus functional index, tinnitus severity scale. So this scoring system will help clinicians to assess tinnitus severity and impact. It will help to monitor treatment progress and outcomes. It will compare individual results to normative, and it will evaluate all what it takes to outgrow this tinnitus problem. Some specific scoring guidelines for common speech therapy. For the speech therapy, you can use clinical evaluation of language fundamentals. It's the name with the 100 and standard deviation is 1 to 50. So interpretation higher scores indicate better language skills. We have Peabody picture vocabulary test as well as one of the scoring measures. So this one too, we check the standard score, and interpretation will indicate better receptive vocabulary. So Western Aphasia Battery, scoring aphasia quotient, it will show about the score in communication or scores of the communication ability. Those scores, strength, severity, instrument, all these are specific scoring guidelines in speech therapy practice. The result of outcome measures in rehabilitation after you are scoring the standardized outcomes, what are the advantage, or what should we say the reason for doing it? It will improve functional ability, enhance performance in daily activities, mobility and balance. When you score somebody to get higher score, the person will be improved, and the sickness will even disappear by half solved. So increase strength and range of improved muscle power and joint mobility. Pain reduction will be there, decrease pain intensity and improve pain management, enhance cognitive function. You can improve memory, attention and processing speed, better quality of life, improve patient satisfaction, well-being, and the like. So all this will improve patient satisfaction, increase satisfaction with care and treatment outcomes. And all these results can be measured through all that we have mentioned. Interpreting the results of outcome measure. We just finished with the scoring of standardized outcome measure. Now about the interpretation of it. So the interpreting the result outcome measure is one of the ways, one of the means to check what have been completed in the outcome, what have been examined, what you have scored, ability to analyze and interpret it is what we want to discuss under this slide now. And if you examine the cause and pattern of the patient, this will require the knowledge and expertise in understanding the specific measure to use or that have been used. So the rehabilitation practitioners need to analyze the scores and compare them to the established norm. Somebody that couldn't hear well before was referred for hearing aid use. After purchasing the hearing aid and you score the behavior or the result that the person will use from the use of hearing aid, then you will score it. Then to analyze, it will help the interpretation process and it will provide cut-off score. Okay, I expect this patient to score 50. To score 80 in the use of hearing aid, but with all my measures and the score, I can interpret it to be 50. What and what do I still need to do? So importance of accurate interpretation is because we want to ensure informed decision making to help us in making decisions that will bring further improvement diabetes, and it will help in optimizing treatment with accountability. It will enhance the patient's outcomes. It will facilitate communication. It will reduce error and risk. It will promote evidence-based practice. It will respect patient autonomy. Yes, and it will maintain professional credibility that shows he really knows what he's doing and what to do by bringing solutions to this, by helping me to have improvement in what has been disturbing me. So when you are interpreting and you're analyzing results, what do you supposed to do? You have to compare the norm. You compare to norms what the person brought, the concern of the patient, what the case history reads, how it was described from the initial point. You have to evaluate scores against age-related or condition-specific norms. You have to compare the current score to the initial score to determine if progress has been made. You have to determine significance. That is when you evaluate if the change is statistically significant or clinically meaningful. You have to consider the context. You have to take into the account the individual starting point, any external factor that may impact progress. You need to see to that. You have to evaluate against norm. Compare the score to normative data so you can understand how the individual progress leads to further. You have to assess goal attainment. What exactly was your goal? Seeing the patient, what exactly do you intend to do to help such a patient? You have to determine the individual has achieved their specific goal or target. You identify trends, look for pattern or trends in the data to inform future intervention. What and what can you still do to add to the improvement? Well, to consider multiple measures. You integrate treasure. You have to integrate treasure. To integrate results from multiple outcome measures so you can gain a comprehensive understanding. You have to consult with others. You have to collaborate with the individual, with the family of the patient, with the healthcare team, so you can be sure of accuracy.
Hello? Are you all hearing me?
Yes, sir, we can hear you, sir.
Okay, all right. So I'm not hearing the presenter anymore. I'm not hearing Dr. Jate Ibu anymore.
Likewise, I can't hear Dr. Ojetunigbe again. Maybe they need to check it. So thank you, sir.
Okay, so let me see if I can continue where he left off, where she left off rather.
No
Are you
problem.
seeing the video? Are you seeing my screen? Are you seeing the screen? Excuse me.
Yes, sir, we can see.
You can see, sir.
Okay. All right, just to take off from where she left off, she probably has challenges. Continuing.
No problem. No problem, sir.
So you can see that there are overlaps in the presentations, in the outcome measures, the key terminologies, in the outcome measures that we use. Some of the outcome measures are specific to each of the rehabilitation professional. For example, hearing tests, audiology examinations, tests of specific conditions such as tinnitus are part of what is considered to be within the outcome measures and tests that are within the precinct, that are within the purview of speech language therapist and audiology. And you can see that she have actually shown us extensively what practices elsewhere, like abroad, looks like in terms of equipment supply. And especially she was able to show us some of what what speech therapists do, some of what audiologists do, and a lot of little bits of things that other rehabilitation professionals do, in the developed country. She was also able to show us some of the equipment that are available, the gym that are available in some of the developed country. So just to continue from where she left off, scoring is important, and there are key aspects of scoring: the ranges, the system of scoring, how it is compared to the nomogram or the criterion. What are the raw scores or raw scores, or are the scores scaled or normalized, as the case may be? The Z scores are part of what some of the instruments use. Of course, the psychometric properties, including the reliability and validity, are part of what we take into consideration in understanding the scores specific, and as well as in choosing the instrument that we use. We also try as much as possible to contextualize the course, making it language specific, make it culturally specific, that is adapting, which is what I talked about in one of the questions that were raised. The scores are usually already marked out in terms of, if you score within this range, the condition is mild. If you score within this range, the condition is moderate. If you score within this range, the condition is severe. All the outcome measures are patterned like that. You can also compare scores with what normal people or average people have in terms of score in that area, in that outcome measure. And of course, you also have to take into considerations the error margins in the scoring of the individual. For statistical purposes and interpretation, we use those scores for studies, for statistical analysis, either descriptives, in parts of percentage, mean. We also use it in drawing inferences, but we also use the extent to which you can actually take into confidence the result that you get. Confidence interval. We test hypotheses with it. We conduct regression analysis with it. These are statistical permutations that we do when we use outcome measures. Survival analysis, meta-analysis, analysis of variance. Those are statistical terms that we use, statistical inferences or tests that we conduct when we use outcome measures. And I don't think we need to go into details of all these hypotheses, p-values, you're familiar with that, statistical significance. But the important thing is to recognize that outcome measures are actually what makes us to be able to actually describe situations and conditions, to make inferences based on the data that was collected, and to give confidence or the level of confidence to whatever data we collected. That's basically what we use outcome measure for. In conclusion, we use outcome measures to summarize key findings. We use outcome measures to interpret results of our findings. We use outcome measures to identify progress when we assess a patient. We also use outcome measures to recommend the next step or what is to be done next. Of course, as I said before, we use outcome measures to communicate results clearly between ourselves, rehabilitation professionals, as well as between other professionals in the healthcare industry. We use outcome measures to document results, make recommendations, and to determine whether we want to continue managing the patients or even make referral. If we do what we have to do, using the right equipment that is specific, that has good psychometric properties, we can ensure that we have a very safe care. We can ensure that we have a comprehensive care for our patient. We can ensure that we provide a patient-centered interpretations of outcome measures in the way that makes sense and meaning to the patient themselves. And we recognize that outcome measure is not only to measure progress made by patients over the course of care, it is also a means of guiding us as to what are the things that we should do in terms of providing care for patients. So I have talked about assessing body functions, activities, and participation, which is basically what International Classification of Diseases and Health and Disability have told us. Body functions, what are those things that we do? Activities of daily living, self-care, activities that we perform. What do we do? Interacting with all each other. Is either self-care, is all that caring for other people, is either participating in other activities of daily living that are considered to be instrumental. It also includes what I considered, as I said before, participation within the society level. It's one thing to be able to do certain things. It's another thing to be able to do something at the community level. Just to give you an example, somebody is able to perform basic activities of daily living function, but can that person garden? Meaning that can he have a small plot of land around his house with which he can walk and do a little farming, which is considered to be part of instrumental activities of daily living? If he's able to do that, that's fine. But is he able to participate in community farming? If, for example, a community decided that we want to cultivate a plot of land for the consumption of food in the community, and we require individual to pay in time to participate in that activity, is he able to participate in those activities? That is the participation level, restriction of which is also important in assessing the patient that we see. Environmental, that some state governments should do every Saturday, is part of participation restriction that will make some people, if they are not functioning at the higher level, to be able to perform. So it is important to recognize that body functions, impairment, functional limitations, participation restrictions are key terms that we need to cultivate and use in the course of our practice. It is very, very important. As I said before, there are ways of assessing patients. The method that is considered to be objective, that is standardized, and the method that is not considered to be objective. But what we do in monitoring what we have to monitor? We gather information. We verify the information that is provided to us by our patient by cross-examining the patient as necessary from time to time in the course of interview. And then we try as much as possible in the course of gathering data about our patient, identify patterns or habit or what is recurrent in the complaints or in the report that is obtained by the patient. And then, of course, we do test and measure where we evaluate, or validate whatever patient is claiming in terms of his inability to do one thing or not to do the other thing. We evaluate that. And then we provide care and monitor changes, and on and on. Of course, our assessment involves the treatment plan that we provide for patients. And we want to make sure that everything that we do is to enhance the patient care or the care that we provide for patients. It is critical to understand that even in ethics of what we do no harm. Beneficence is important. Everything that we do, in addition to not doing harm, must be something that will benefit a patient. We may not conduct experiments on a patient. We cannot provide care that we know is not validated either anecdotally or objectively to a patient. Otherwise, we can be said to be harming the patient. And these are key things that we have to put in mind in doing what we have to do. And Dr. Ojeto added that while we are observing, we must be objective. We must not be biased. We must focus on the specific aspect of behavior or function for which the patients have come to see us as a result of deficiency. We use standardized tool and checklist, as we mentioned. We consider that the standardized tool that we use are applicable to our patient that we see. Preferably, we should have standardized tools that are actually validated or interpreted or translated, into the local languages. We want to make sure that in doing what we are doing, we know that we have to maintain dignity and make sure that there is privacy, for the patient in anything that we do. Confidentiality of information, consent is important each step of the way as we provide care for a patient. I think this is what Dr. Ojeto is trying to emphasize here. What does interview do for us? It helps us gather information. It helps us to clarify observation. Of course, it helps us to assess, the state of cognition and the emotion of the patient, emotional functions of the patient. We need to be able to understand patient goals and priority. It is through interview that we get that. We need to be able to be familiar with the level of restrictions in participation and social engagement by the patient. It is in the course of interview and assessment that we are able to gather that. If there are specific environmental barriers in the society, I talked about society level of restrictions before, then we are able to understand that, and we're able to compare, understand or compare what is available in the community that will likely, even if the patient gets well, restrict the level of participation in the society. And as advocates, we are also responsible for making sure that we advocate for the removal of whatever barrier that is available or is present in a society. And what is important in today's world, the buzzword is patient-centered care. Patients are the king. In fact, evidence-based practice suggests to us that patient preference is important. Patient preference is key and important. If a patient comes to you and he told you that a physiotherapist or anybody, a speech language pathologist, audiologist, that he has this condition before, and when he had this condition, this was what was done, and he or she got relief and improvement that is satisfactory. Because of that experience by the patient, it is mandatory that we choose that modality that the patient reported that helped him first as a matter of priority. And that's very, very important. And that's one of the cornerstones of patient-centered care. Patients are the king. They determine the care. We are knowledgeable. We are experts. All our job involved is to provide options, for the patient. And where possible, the patient can actually choose the option that he or she prefers in providing care, in receiving care that he needs to receive. We must be able to listen and show empathy while we are interviewing a patient. All our questions must be open-ended as much as possible so as not to lead the patient, into a conclusion that it is not intended before. So make the question as open-ended as possible. Make sure that our interaction with the patient is not judgmental and is also respectful in terms of how we ask questions, and in terms of how we present ourselves to the patient. We should avoid leading questions, as I said. If possible, where possible, we should use visual aids to facilitate communication. We should consider cultural and linguistic diversity in interacting with our patient. Of course, we should make sure that, as we said in the course of this lecture, standardized outcome tools are used because they are key. So body functions, refer to physiological and psychological function of the body system, organ, and structure. These are definitions of impairment and functional limitations. We don't need to go through that in detail. We know what impairment is: anatomical, physiological limitations, and so on and so forth. Absence of a body part, and so on and so forth. Functional limitation, we understand all that. We understand what all those mean. And there can be varieties of functional limitation. Mental functions limitation can include being unintelligible or intelligibility, can include being able to reason well or unable to reason well, of course, can include cognition and memory, as I said before. Sensory function and pain in terms of hearing, vision, touch, taste, and smell, and pain, specific complaint by the patient in terms of physical, ailment, are part of, what we use in defining body functions, that we examine in patient. Speech language therapists will use voice as an important key tool in determining the specific limitations in the functions of the body. Of course, Dr. Ojeto will further emphasize that there are cardiovascular functional limitations, there are hematological functional limitations, immunological functional limitations, respiratory functional limitations, capacity, ventilation and oxygenation, aerobic capacity, and so on and so forth. She went on to elaborate on that. There are examples of body functions: digestive, metabolic, appetite, digestion, bowel, genital urinary, which are systems that we review normally. Neuromuscular and movement-related functions, endocrine functions, functions of the skin and related structure, integumentary. These are part of we do under system review, under examination that I talk about in the first part of the lecture. Activities, what do they mean? They refer to specific tasks or actions or experience that an individual engages in to achieve a purpose or outcome. It can be physical, it can be cognitive, it can be emotional, it can be social, it can also be spiritual. Participation refers to the level of involvement in situation, activities, and role, but those roles must be meaningful to the patient. To give you an example, a mother, a 32-year-old mother of a baby, one of the key functions, if it is deficient in the patient, that the physiotherapist or the occupational therapist or the person that is providing care for that patient will be concerned about, is his or her ability to back the patient, to carry patients on our back. We will not do that for a man who comes for treatment, for physiotherapy, for occupational therapy, for speech language. We will not consider that because the specific role function expected of a 32-year-old mother in our culture is to be able to back a baby. I know that today many people are not backing their baby anymore, but the specific role culture that is expected of a mother, 32-year-old, includes being able to back a baby. We will examine that as part of the key functional examinations of any action that is deficient in a mother, 32-year-old mother, whereas we will care less about that in a man. Just to give an example. So she went ahead to list activities and participation examples. Activities of daily living, which can be physical, it can be cognitive, and then participation, productive, leisure, community level such as environmental, even domestic activities, civic participation, church going and praying in the mosque, and so on and so forth. They are part of activities, definition of activity. She also provides context to this activity, related to specific action, and context in health that is related to participation, and they are key for your understanding. When you are addressing body functions, what do? You observe and ask physiological functions. When you are when you are assessing body functions, you also use standardized measure. When you are assessing activities, you observe and you use standardized measure. When you are observing participation, you examine or you observe, and then you also use standardized outcome measure. We are repeating what we have said before: assessing body functions, assessing the activities of daily living, assessing participation restrictions are core things that people, our colleagues, we in the rehab profession do. When you combine observation and interview, you come up with problem list. You triangulate by connecting dots based on the examination and interview. And then you use the interview to gather more information. And you use that information to generate a problem list, which is important in providing care for our patients. And there are considerations for all these things culturally, environmental and context, individual patient experiences and perspective, and family and caregiver involvement. These are important concepts that we bring into bear in providing care for a patient. We also evaluate outcome. We plan, we collect data, we analyze data, we report data, we utilize the data, and we evaluate outcome. Based on the evaluation, we come up with what is considered in many instances with, that is called diagnosis. When we make diagnosis, we label the condition. And what is the purpose of evaluation? The purpose is to make sure that we have an idea as to what we should do, because we are accountable for what we do. We have an idea of the baseline so that we can measure improvement based on the baseline. We have an idea of what is learned in the course of care by the patient as well as by the provider. Through the observations and the planning that we do, we also come up with a step-by-step process to guide our reasoning in terms of what is to be done for a patient, in terms of how that this is to be done, and in terms of what the communication that we need to provide for, in order to enhance the care or maximize the care of the patient. Well, she went further by common evaluation method. There are clinical outcome measures, there are surveys and questionnaires, there are interviews and focus group observations. There are also RCT. We don't need to go into details of this, but these are important common evaluation methods that we use in practice. But for purposes of clinical outcome measures, surveys, and questionnaires are key in determining outcome of care in patients. When or what are outcome measures to be measured? I already stated that: effectiveness, efficiency, impact of the diseases, sustainability of the whatever achievement we have made, patient satisfaction. If there are lessons learned and future direction, accessibility issue can also be part of what can be outcome measures that are going to be measured. Again, for purposes of this group of people, for purposes of our practice, the outcome measures are designed to evaluate impact, effectiveness, efficiency, patient satisfaction. Those four are actually the key determinants of what makes us to choose outcome measures in practice. So I won't go into details about evaluation designs and methods. That's beyond the the scope of this presentation, but it's available for you to access. And timeline, that I already stated it. Some patients with conditions, if they are acute, very acute, like low back pain or any kind of pain, you measure every session. You measure every session. So some patients can be weekly. For most rehab patients, it will be weekly or it will be bi-weekly. But for some conditions, pediatrics and chronic progressive diseases that we know is progressive and will continue to bother the patient, then the period of evaluation, can be 3 months or can even be, 6 months. So data collection and analysis, these are part of what we do usually in research. We don't need to go into details of this. Outcome findings, what do you do with outcome? We use it to discharge patients or to make referral. We also use it, we collect the data system-wide, hospital-wide, or departmental-wide. When we collect such outcome data, we can use it to improve quality of care by self-examination of the care that we give. We can actually use it to improve quality of care. Where are we doing well? How many times, how many sessions are our patients with stroke? How many sessions of therapy are they getting before they improve to a certain extent? How does the number of sessions that our patients in our own facility receive when they have stroke before they improve to an extent, how does that compare, the number of sessions compare with similar facilities in our region or in the nation? Those are some of the ways we use outcome of evaluation tools that we use. And of course, we can use charts and all this histogram, bar charts, and summary of data to do what we have to do. And we also use it to discuss implications of findings, and so on and so forth in course of care. So this is the end of the presentation. And I think if there are questions we can take at this time. If Dr. Ojeto Ibo is back, she can take the question, but otherwise I'll take the question. Thank you.
Thank you, sir.
Yes.
Thank you very much. I tried reaching out to her, but I was unable to reach out to her. So I don't know, maybe she's having some challenges presently. So she's not back online yet, sir.
Okay, all right. So should we wait or we take questions? And then if she comes back, she can continue with her lecture. But
we don't wait, sir.
A summary of what it should be.
We can just take the lectures on our behalf, the questions on our behalf, sir.
Okay, all right. So questions, and that can be questions, for the two presentations. Again, it's important to emphasize that there are areas of overlap in the outcome measures that we use. Of course, there are some that are specific. Areas of overlap is a lot between occupational and physical therapy. Areas of overlap is a lot between speech language therapists as well as audiologists. But there are areas of overlap. But the common theme is that outcome measure is outcome measures. It's a tool that we use to assess progress for quality of care and for other reasons. So it's important to recognize that. Again, outcome measures are simple. They are not difficult to use. Again, in Nigeria, we find out that outcome measures are seldom used. They are sparingly used. We need to improve. We need to make progress. It is key and critical. They are simple to use. Of course, we recognize the challenge that at our end, in the academics or even in the clinic, we are responsible for doing research. We should make sure that we interpret and culturally validate and adapt some of this equipment so we can use them. For the most part, the equipment that we have now in English language for numerate and educated people in Nigeria, our country, they will be able to use them. But for some people that are not, numerate or not educated, as some people, it is important that as a service to the community and society and nation, we should try as much as possible to interpret or translate and adapt some of this equipment. One thing that I also want to emphasize is the fact that before we finish with the translation and cultural adaptation of the equipment, it is key and important to let you know that most of these outcome measures, clinicians can actually administer it for a patient. But what is necessary is the consistency in the language and description of its use. Again, I want to emphasize that virtually all these outcome measures, clinicians can use them. Even when the patients are not highly educated to the point that they can complete the form themselves, clinicians that are well experienced can actually use it and administer it on behalf of the patient. But to do that very well, they have to have a standardized translation that they have developed themselves, so that they will be asking the same question, to the patient. They won't be asking a patient patient A this question or this item, administer it like this, and then patient B, they administer it in a different way. They have to standardize the way, and that's up to the individual physiotherapist, occupational therapist, speech language therapist, and audiologist. All the instruments, even when they are not validated as yet, even when they are not adapted as yet, even when they are not translated as yet, individual clinicians can use it. But the important thing is to make sure that they standardize the language they use in administering it. And that's key and important. And I think I want to emphasize that. Again, questions? Questions? Let's take questions.
Please, you can kindly unmute or raise your virtual hand if you have any questions.
Okay, let me see. Should I unmute? You have to, I think individuals will have to unmute themselves. Yeah, because individual will have to unmute themselves.
That's correct, sir. Actually,
so unmute yourself if you have any questions, please. Any
Dr.
question?
Jetoyin-Boma, you can conclude the the presentation. She's back on. She did not know she was offline since she's been giving her presentation, but she didn't know that we could not hear her.
Okay, all right. So
Yes,
she's is she concluding now?
Dr. Jetoyin-Boma, please, were you concluding now?
Okay. Okay. All right, she's not there.
Hello?
Hello?
Yeah.
So she's back.
I don't know that I've been cut off and I was talking to myself.
So can you conclude, please?
Okay. All I want to say is that in audiology, assessing function, activities, and participation involve evaluating how hearing and balance disorder impact an individual daily life. So when you are evaluating auditory and vestibular function, when you are trying to assess the body function through this vestibular test, hearing threshold and speech recognition should be considered. Balance and equilibrium, tinnitus and sound tolerance must be checked, and auditory processing and cognition must be assessed as well. And we want to check the activity part of this vestibular issue. We need to assess impact on daily activities. How is the patient communicating on phone or conversation? We assess his activities in relating socially and in legal activities by watching TV or listening to music and the like. So we want to see through the angle of participation. We have to evaluate involvement in life situations. Social relationship and community engagement, employment and education parts, recreation and leisure activities, family and daily life activities. That is how you will know, how you able to assess the participation of the individual. The assessment tools to use, as I mentioned before, from standardized questionnaires. All these audiology tests can be used. Your tone, speech audiometry, vestibular assessment, rotary chairs assessment, observation and interviews are the tools to use to assess the body function, activities, and participation. The purpose is to identify impact of hearing and balance disorder, to develop a personalized rehabilitation plan, to help monitor progress, how much improvement as the patient develop or has. I have to inform hearing need and assistive technology recommendations. It will enhance patient-centered care and community. So by assessing the body function, the activity, and participation, audiologists can create tailored rehabilitation plan addressing the unique needs and goal of each individual. That the last subtitle is about evaluating income, and all basically is our planning. We are to evaluate outcomes rather. You have to plan, then data collect. You have to collect all the data that are necessary, analyze all of them, report them, and recommend how they will use. This is what survey of evaluation outcome is all about. Thank you. Can you hear me?
Thank you, Ma. Are you through with your presentation now, sir, Ma?
Hello?
Yes, Ma, we are together, Ma. Are you true, Ma?
Yes, yes.
Okay, Ma. Okay, Ma. Any questions, please?
Yeah, good afternoon, Master. My name is Kelani.
You can go on. We can hear you, please, sir.
Thank you for the prof presentation and Dr. Jetoimbo for the procedures so far, because I know most of it has to do with procedures and how it's being done, considerations to use. But I wish to have an information on the in an instances when we work audiology particular on a threshold, and I know there are frequencies considered for threshold to be determined. But in these instances, that a patient have more of the loss on speech frequencies, and we look at mid frequency with the one that followed up to like 4,000 for calculating, considering pure tone audiometry investigations. How best do we think this patient can be convinced of why there is more loss on the speech frequency and the better way out to help this patient? Because after, let's say I'm bringing this in, it's not part of the topic, which has to do with rehabilitative measure. And we felt like the better off is either on amplification or the likes. And this patient is still complaining of, I can perceive better when a man talk than when a woman talk. Do we think the best modality should be that, or there are other therapeutic approach which can be in place to assist such patients? Thank you.
Okay. Shall I go on? Hello? Hello?
You can kindly respond, Ma.
I'll respond, ma'am.
All right. Okay. Thank you, Mr. Wali. In audiometry, threshold are used to determine the minimum sound intensity that an individual can detect. And there are many ways to confirm whatever that we get as threshold. It is ASHA, American Standard and Hearing Association, that brought about ideal of using the frequencies, the decibel ready at 500, 1,000 to divide by 3. And another school of thought says, how come the frequency as representation in this that we are doing? Then introduced 4,000 to be part of threshold method. That is 500, 1,000, 2,000, and 4,000 divided by 4. And whatever you now come out with will be your threshold. But there are other ways of checking all these ones. Is when all other things are not considered or compared together. That is when such an individual can be placed on the use of hearing aid, and the person will not benefit maximally. Like what we call hearing threshold is that one determine the minimum sound intensity that an individual can detect. There's something we call speech recognition threshold. It will help the individual's intensity to be to understand the recognition level of by the individual. That right there will know, and speech listening can can perceive, can speak. How much words does it have? How much spoken word does it have? Is it around that 50% as we used to determine it? What is the standard of bone conduction in this we do? Where exactly is the bone conduction fail as we assessing, examining the patient? Some patients, they have profound sensorineural hearing loss. The BC, their bone conduction level could have reached around that 70, 70 is the last mark for it, around that 70, 60. See, you still claim on the hearing, on this of hearing, it cannot work. Such a patient will not benefit. Such a patient will not benefit. Even our air conduction test, which part of the air conduction results are affected? If it is high frequencies, majorly, if it has reached a profound level as well, it may be difficult because with what they call sound distortion. Patients may be hearing but may not be able to discriminate, may not be able to understand or comprehend the speech that is listening to. Is that can cause so many patients to be placed Hello?
Yes.
It's my voice said that.
Yeah, Dr. Jatoyibo, thank you. I think
Yes,
the young man, I think there is an aspect of your question that I think perhaps Dr. Jatoyibo should address. And that aspect is the gender issue interplay here now. Will there be anything in terms of the physics of sound waves that makes the patient to claim that when men speak, she's able to hear them compared to when women speak? Are there physics of sound that is involved here? Perhaps secondary sexual character that is developed over the course of time, puberty, adulthood. I think that aspect is important and germane as part of what the young man is talking about. If Dr. Jatoyibo can respond, bearing in mind the physics of sound as it relates to sex too, perhaps that will elucidate or provide more insight. Am I right?
okay. Okay, sir. Let me still go to that side. No, okay. Not, but let me still touch that aspect. Sound waves are known as fixed solid can have different effects on individuals based on their gender due to various physiological and anatomical differences.
Yes.
And there are some examples to consider when we are talking of hearing range. Women tend to have a wider hearing range than men. Yes. Especially in the higher frequency range. That's why in the choir you see some women will be singing this what they call it? Is it solo or what they call it?
Yes, not the baritone, not the bass.
Yeah, exactly.
Yes.
Exactly. So also in the aspect of hearing sensitivity, women are more sensitive to sounds in the higher frequency range, while men are more sensitive to sound in the lower frequency range. This is to explain that later. And sound localization too. Women are generally localizing sound in space than men. That's why we always love to hear the word love from outside, something positive. We localize our ear, look for good news, look for positive things, because that's how women were made. That's how we are made. So sound localization women are generally better at localized sounds in space than men.
Okay.
Noise hearing loss to talk. Men are more susceptible to noise hearing loss due to their greater exposure to loud noises, maybe due to their occupation. You understand? Most of the vigorous work. Men are liable why noise reduce hearing can still make them, and if that happens, it will affect their pitch, high frequencies, and majorly they may what will have caused sensorineural hearing loss may be different from what caused in the male. It's most about this occupational noise we are talking about. What caused sensorineural in woman is just liable to inner ear issue, not noise induced. It's possible such a woman may be able to achieve more in the use of hearing aid than that of the men. And when we're talking of physical perception, research suggests that women are more sensitive to musical nuance and they have a greater appreciation of than men. That's why you see men, either they like or they do not dance, their body will not move. Everything about them in receiving, in perceiving, you cannot compare it with that of the women. First perception as well, women are better at recognizing and distinguishing differences than men. Auditory process, women have to process auditory information more efficiently than men, especially in noisy environment. So I think it's hormonal influences, something that is now, still related to all those things. These differences can still make it easy for women enjoy the use of hearing aid or hearing better than our men. Thank you.
Thank you. So any other question? Any question? Any
Good
question?
afternoon, now.
Yes. Or comments?
Yes. Good afternoon, Prof. Good afternoon, Dr. Jotuimbo. So I want to appreciate you both for the nice presentation. But my question actually pertains to a personal issue I've been battling at my workplace. So in our workplace, getting technicians to come calibrate our devices, and then in some cases, when some devices stop working, getting technicians to come check and repair has been a major issue. And I think this is because most times for us to evaluate, assess, diagnose, or do anything, we depend on audiometers, OE machines, then the tympanometer and other like the ABR screener and all that. So how do you get to source easily for these technicians, for them to calibrate, and then for them to check to know if it's actually due to calibration that the machines are not working or due to some other, internal issues?
It's a big question.
You, Dr. Yes.
Thank you very much, my brother. To get technicians to come and repair equipment in an audiology office or practice, it doesn't come like a magic like that. I is supposed to come officially. There should be a way. Like from I was working in one teaching hospital before I moved to this present one. Where I was working for, from day one, I established that relation and I make my information that from the way I was my equipment, number one, must be calculated annually. Number two, must be checked occasionally. And I need the technician. If possible, employ somebody as a technician that will attach to me and to any other office I may not know. But we need this thing as time goes on. I make my clear, needs, my clear information about that they should provide clear things about technician. And the man said I should write the biomedical department about what I want, which I made known to them. But to my surprise, they told me that all their studies did not cover audiological equipment repair, calibration, and troubleshooting. That I should suggest to the management for their further training. Maybe one or two people should go for training. And indeed, the management welcomed that idea and trained one person. That person could have been the only helper in this Nigeria for today. But very fortunately, he fell sick and died. So throughout staying my OG, no issue. The nation was working on it. It was working on my equipment regularly, annually. Any need for any technician work, immediately I call, he comes and we do this work. But where I am presently, I'm facing what you are facing, as you said. So, and the question I've been asking, is there nobody to go and learn about this? Because throughout the whole nation, they will say, if you have to calibrate your equipment or work on it, it must be, take to outside country, which will delay patients that are waiting already. We still delay them. It has been a challenge. It has been a challenge everywhere. But what I will suggest, official suggestion that I will give now is that, number one, you need to establish relationship with biomedical people. Establish relationship with them. Get a particular person, like a member of my team issue. I told the management, they gave a contractor to go and work it. After 2 weeks, the probe is still not working. I don't have the audacity to go and face them again and say, this one that we sent out for over 6 months that has not been functioning, is no more functioning again, even when brought after 2 weeks. So I needed to go to biomedical people and liaise, particular what they need. No, is very good in only he doesn't want to I'll give it out free, because he said he trained himself, but he doesn't want to give it to the government. Do you understand? So schedule regular maintenance should still be done. It should still be done. Maybe once in every 6 months. You can carry out bio check, as in every 6 months. Gather 2 or 3 people in your team, test run all these things on them. Let's know what they function. And don't wait to your movement. Begin to write letter. Keep writing letter till the management will be well informed, so they can see what they can do about. So that's all I say about that one. But at the same time, one of us, 3 of us, need to do calibration. If anybody has certificate, plans to do, and all people that when will come and tell me that they don't, the company said this, the company that trained them said they must not touch the equipment. Why did you not go for the training? It's my problem. So it's the same problem I'm facing, my dear brother. So God will help us to go about. Just keep maintaining it. Check on yourself. Use it to test run on people. If you detect anything, quickly let the management know if you should buy another one or to send it up for repair. Thank you.
Another quick thing that I can add to that, yes, I can add something quick to that. And that is that each time we went for accreditation, equipment check is one of those things that we do. We check all the equipment. We check for the calibration. We check for the date of inspection, for accuracy, and for other things about the equipment, safety. We check that those equipment are being used in a manner that is safe. Now, I know for the most part, some of our colleagues may not be too much aware or pay too much attention and focus on things like that. It is important that we focus on that too. Where equipments are too old, they are not serviceable, they are not being calibrated, it's a safety issue. And that's an issue that can actually cause an accreditation, a facility to have an adverse report about them. Because what is the essence of service or care that you are providing with equipment that are unsafe, that are inaccurate? But except accreditation team spot that, identify that, they will not reinforce the efforts of our heads of department or heads of program or director of programs in making sure that the best care that patients should get is being provided for them. So we will not just rely on the individual proactiveness of people like Dr. Ojeto Yibo. It's important that people that are going to accredit facilities also look at that and take it serious. But what is the essence of service that you are providing with an unsafe equipment, with an equipment that is not accurate, that has not been calibrated, that has not been examined by the engineering? And I understand the degree to which our attitude to work, our work culture in Nigeria can be a factor. There's nothing wrong in the engineering department in themselves being concerned about the equipment in the facility, and as a result, make recommendations, train their staff, make sure they train their staff. There's nothing wrong in that. But as usual, our culture, not our culture, our attitude as usual will be so that's not too important. But I think accreditation team going forward should be emphatic on that. If you are using equipment that have not been calibrated for years, if you are using equipment that we don't know whether it is safe, we don't know whether, no, it means that you are rendering perhaps unsafe care. And that's something that should cause an institution to have an advanced determination. I think we have to get to that stage in Nigeria. And I'm, for all of us that are in the, listening now, we are probably going to be part of the accreditation team. This should be part of what we will focus on. You have all the staff that you have in you need to have in the world. You have all the equipment that you need to have in the world. But the equipment, we are not sure they are bad. The equipment, we are not sure they are safe. What is the essence of the care that you are providing? So that can cause the institution to have an adverse determination. By the time we begin to do that, they will be taking it serious. Again, we will not stop pushing engineering department, the department that is responsible, to also make sure that they are also doing their bit. If you are a head of engineering, you don't care about whether equipment in physiotherapy, audiology, speech language, you don't care whether they are calibrated or they are inspected for safety, you don't care. Is that your attitude to work? Then you are nowhere. I think it is part of what we will have to make people that are supposed to do the job accountable for. It is also their responsibility. So it's important to bear that in mind. People that will be accrediting agencies or hospitals or care, they are part of what we should focus on. And it's genuine and germane. If you are providing care with an equipment that we are not so sure it's safe, then you are as good as not providing care. Why are we sure you are not harming patients? Even when we are documenting that patients are making improvement using alcohol measures that we hardly use. So it's important we also emphasize that as far it's a collective responsibility. We will not just the of Professor Ojeto Yibo alone. That's not enough. That's not, she has her duties that she has to do. But if she has to be, seeing the engineering department to do the right thing, that's taking an extra thing out of her. So we are all involved, and accreditation, members, people that are accrediting agents, our hospital should also be focusing on that. It's important and critical. Thank you.
Mrs. Dorcas, you can speak on now. Thank you.
Okay. Good afternoon, everyone. Well done. Thank you to the two beautiful presenters, my most senior colleague. Thank you very much, ma. Well done. My contribution is on the calibration and then maintenance of equipment. Like she has said, there is a lacuna in getting professionals that would assist with calibrations of equipment. But I also think that during calibration, there's an aspect where it's always assessed to see in facilities where there's audiometry going on, that there is more than one audiometer. So I think that also can bridge the gap, whereby if you have one audiometer that is out of use or is out of calibration, one can still be functional. So if the accreditation team also, like Prof just rightly said, do due diligence and ensure that all these things are put into place when they go for accreditation, ensure that the machines are in the numbers that they are supposed to be, and that they are working accurately, that they are supposed to work. This will also bridge the lacuna, since the professionals to do the calibration are not here in the country. So when they send one out for calibration, you are sure of having another. Like, for instance, I know government institutions that I know that they have more than one audiometer or one other machines that is more than one. And when they have one that is not working, it gives you the room to have the other one that is working. So I think the accreditation team should also look into that. And secondly, also, we also need to work on orientation of the biomedical department, just as Prof has said. He has said it all, really, that they also need to really be enlightened and informed and probably trained. It is not our responsibility to always say that they should be trained in that aspect. It is a gap in their own education if they cannot work on such a machine. So it is important that they also refurbish and refine-tune themselves to be able to attend to. If they can attend to other machines that are used in the health sector, why not audiology? Why not audiometer? Why not other audiological equipment that we use? So I think it's important that in all our institutions where we are, we should ensure that the biomedical department are also on their toes. Even though some are there and they are just as if that they are not there. That's another thing, because they are not doing their job. You don't even know that they are there. You ask if they are there, you do not know that they are present there. So it's important that we put them on their own toes also to do their job. And that can only be done if we have an institution head that is vibrant and that is interested in this aspect of audiology. So it all boils down to that. Thank you very much.
Thank you.
Thank you, sir. Sorry, this is Wale on the line again. In calibration of the machines, yes, I think part of the principles of gadget supply has to do with regional recognitions. In most cases, I think there is not any machine, if normal procedures are being followed, supplied, that would not have regional representative. Representative might not be able to do much about getting it calibrated, but serves as a link between the institution and the manufacturer. So when the of calibration comes, I'm sure there are some people that supply the center machines. So if contact is still retained, there will be better way to get it calibrated. Yes, there are some talking about other professionals too. I'm being precise about audiological equipment, for example now. I think, yes, there are some of our senior colleagues who are having franchise with some organizations, some manufacturers that produce some equipment, which with them, they have what they call a trademark. Because of the trademark, it makes it difficult for anybody to just tamper with the machine, because they believe that's why they always request, let us on. Some might even get to their representative and they will be able to do one or two things and feel that the calculation is done with the use of a code, because some of them use codes. Only a code for representatives, not for everybody. Now, to get it of it, what is our link with the machines we are using? What's our link with? I'm not being, that's not only for audiological equipment, all equipment, because somebody supply it. It's not that we just go to market and keep it. So if that it is, there will always be a link, and getting it calibrated will not be an issue. And with institutions that have professionals that work, yes, if I'm using the word if, the person is a certified practitioner. What certificate has to do with your commitment with your association, commitment with your regulatory body, there will not be one or two contacts that would make you to get things done how it should be done. That's just my own idea about it. Yes, it might be of cost implications, but getting machines done can be done, except if you just felt you don't want to do something. Thank you.
Yeah, yes, thank you so much. Something to quickly add is this. I think we have come to a stage in Nigeria where, for example, all of us, without exception, we have to shun our corruption. We have to make sure that if we are assigned a task to do, we do that task with the fear of God in mind. Patriotism is important. I recognize that in many instances, the heads of hospitals, when they want to do new things, they can call people together to talk about it. What will you need? Audiology equipment that you will need in your department. What are those things that you will need? Now, but why they involve you in that, they will not involve you further where decisions are made. And that's part of why healthcare workers have been crying to make sure that they are also included in the core leadership position. To give you an example, recently in my facility, or a facility that I know, they have some money to build a facility. And that facility is supposed to include all aspects of hospital care in that facility. I think the money was supposed to be maybe 1.2 billion naira. So one of my colleagues was there and was involved. But they involved him at the initial stage when they wanted, oh, what will you need in terms of structure for what you have to do in your department and so on and so forth. And that's it. But at the point where, for example, the money they are looking for is reduced from 1.2 to like 800 billion, they no longer involve that person. Now, they now eliminate the department. They eliminate the department entirely. Now, because they didn't involve him at other levels where discussions are being held, instead of a proportional sharing of whatever they have, so that if we will reduce all services or structures that we have earmarked proportionally, so that if X department or service is supposed to get 10 million, but now is only able to get a proportional reduction of that, then that's fine. If that happens, then he will be able to make that decision. But because he wasn't involved at the higher level where decisions are being taken, then there's a problem. So these are some of the issues. I think our members, especially senior members, should continue to struggle and not be passive. They want to make sure that they are a part of decision-making process. It may involve telling you that, oh, you are struggling you are fighting these people, you are fighting doctor, you are fighting this, you are fighting that. But these are part of the things that we have to get ourselves involved in. It's key and important. When resources are to be allocated, when you are not there, they will not allocate your department or service any resources. And that's one of the things that we have to take into consideration. So all of us that are in the directorship position or higher position, we must put that in mind and make sure that we want to also struggle to make sure that wherever they are making decisions, we try as much as possible to be present there. I think those are part of the issues that we have to take into consideration, and that involves everybody. I think I should add that.
Thank you, sir. I was going to say that because I know what Mr. Olawale is talking about representatives of representations of some equipment manufacturers in the country and so forth and so on. But it's also very important to note that some of these machines are bought without even we, the end users, knowledge.
See?
So you just see that the machines are just brought, just like Prof has said, that when the decision to get the machine is initiated, what do you need? You give a list of what you need. And then after a while, you just see they just bring machine. For instance, I know of a facility that requested for audiometers. And eventually, for diagnostic and clinical audiometers, which is supposed to be used in an health institution, in a teaching health institution for that matter. And when the machines were brought, it was a screening audiometer. They supplied 5 screening audiometers, which calibrations were 2 years before. So were the professionals that will be the end user involved in purchase of that? Definitely no. So just like Prof has said, I think the issue also goes way beyond some of our capacity down here, but we also need to speak up, because when you bring a machine to me that I cannot use, which is not meeting the standard of usage as a professional, I would not use. So you either involve me in the purchase of it or not. Thank you.
Yes. So any other question or comments?
Good evening, everyone. This is Grace Bamgwe. I need to take you back a bit. My line went off when they were discussing the difficulty with discriminating female and male voices using hearing aids because of the frequency loss of the patient. So one, it's important first to understand people that will likely have that issue, people that were hearing before and they have difficulty with hearing along the line by any reason. And then they know male voices different from female voices. So they're going to raise those concerns. But again, the counseling we give them before they purchase the hearing aid, because what they are coming in with matters. So some people will think hearing aids or cochlear implants are automatic. Once you purchase them, you put them on, you're going to hear perfectly well. You know, yes. It's a misnomer. It's very important to educate the patient before they invest in those devices, because they are not cheap. They are very expensive. So you need to bring them up speed, even sign like an undertaking of the extent to which they understand the output of the hearing aid. Don't forget, hearing aid can never equate normal voice. It can never equate it. And it can never equate normal hearing, because the frequencies selected are very limited compared to the natural frequencies on the organ of Corti. So it's very important to educate the patient that, look, this is what you can get from hearing aid. After fitting you with hearing aid, there is that rehabilitation window that you need to learn to listen, which is called a listening training. You need to have a listening program for your patients after amplification. There must be a listening program. And that listening program will account for different noises in the environment, how to recognize them, and how to differentiate them. That person that the patient has that need to learn and unlearn how to listen and listen very well. So female voice, male voice, because female voices are usually high frequency sound. And if you are someone that having difficulty with high frequency, that has high frequency low, will not even hear a female talking, and you will only hear a male talking. So you need to know how to augment that on the hearing aid itself while programming the hearing aid. So you have a whole lot of factors that come to play. First, educate your clients before they sign in for hearing aids. Then when they get the hearing aid, watch out for the frequency to enhance and to program while fitting them. And then let them come back with, give them a note that they will indicate what difficulty they are having in different listening backgrounds. So what it's going to be like in church will be different from when you're having a lecture, or when you are listening to your phone, or when you're listening to the TV, when you're in the quiet of your bedroom, or when you're on the road, or you are in a cafeteria. These are different listening environments that need to be accounted for. We that can hear, we have no problem with our hearing. We're able to adjust to different listening environments. So there is need for post-amplification training where you will educate the client and teach them to learn to listen and get the best benefit from their hearing aids. Thank you very much.
I think Dr. Bamigboye make an important point that I want to also speak to now. There was an instance where I have like a relative who is an ENT specialist. So he told me stories of two patients. He told me stories of two patients. The first patient, patient X. In fact, the state government was willing to pay for, the hearing implant that that person needed. So the state government paid for it, but after paying for it, the patient was not returning, was not coming back for the training. So at the end of the day, it was like there was no benefit to the acquisition of the hearing, the whatever implant. Now there is another second patient, patient Y, who is also a candidate for that. What the patient Y did was to actually meet the relative and said, no, please don't buy any implant. The money that the government will give you, just give it to me. I don't need any implant. And that response was based on his experience with patient patient X, who he happened to know. And he didn't know that the patient X was not coming for a training and the training that is necessary. He just assumed that, oh, okay, government will spend so much money, but at the end of the day, nothing will happen. I think it's important to note that too. Our colleagues, that are in this field, these are part of the considerations that you have to understand and aware and be able to navigate that as part of the total package for patient management and advocacy. Please, it's important to have that in mind too. There are many areas, many states in Nigeria where federal government, state government, if they are aware, they want to pay for it. But don't be surprised that patient will come behind and tell you that don't buy this, don't do this, just give me the money. Don't be surprised. I think that is part of what we have to take into consideration in our total package of healthcare and views. I think I wanted to add that. So, Dr. Karima Tajayi, you wanted to say something? Hello? Anybody else? Hello? Is there any more question? I've unmuted. I'm trying to unmute you. Karima Tajayi, you have to unmute yourself. You have to unmute yourself. Okay, all right. So any more comments or questions?
We can conclude, sir.
Yes.
All points have been made. Yeah.
Okay.
Thank you very much.
Okay. So if there is no other questions, I think I just want to thank Dr. Ojetoyinbo. I want to thank Dr. Tolu Lokoyo, MRTB. I want to thank all the participants. Once again, I apologize for the delay in starting. As I said, I'm in New York, and with the time difference, I woke up in the middle of the night, and I was looking at the time, and I just dozed off when it is close to the time. So thank God, Dr. Tululope called me, and that was when I woke up and said, "Oh my God, I'm supposed to." So I apologize, but I believe everything went well. I hope you enjoyed the lecture. I hope you have benefits that you will derive from the lecture. So the PowerPoints are available to you. You can actually look at them and make use of them as you see fit. So again, I want to thank everybody for their participation. It's been wonderful. It's a good experience, and God bless us all. Thank you so much. The MRTB officials, Dr. Tolu, you can, any passing word?
Thank you, sir. That's all. We are grateful, sir. And Dr. Ojetoyinbo, we are very grateful, ma. Thank you so much for the presentations today, sir, ma.
Thank you so much,
Thank you very
everyone.
much for the presentation. It was
Yes. So
very
enjoy your weekend,
Thank
whatever
you,
is
sir.
left of it.
enjoy your
Thank you.
weekend too, sir.
Yes. Bye-bye.
Bye. Thank you, sir.
Bye.